Has Dr. Murli joined in?
Yeah, he's joined. He's not showing up, but his link is there.
Because he's the second speaker. If he is not in, then you should be the next, huh?
Yeah, sure. I'm sure he'll join in. He's already, his name is showing up, so he should be there.
Ma'am, we are live.
We are all back with you with yet another webinar of ARC on neuro-ophthalmology, and we are ready with a superb expert panel who would teach us a lot more. We are indeed lucky to have with us Dr. Prem Subramaniam, an amazingly prolific personality, MD, PhD in ophthalm, neurology and neurosurgery, and also the Vice Chair for Academic Affairs in the Department of Ophthalmology at the University of Colorado of Medicine. A top-line educational career, faculty posts at the best of medical institutions, served as an army officer and surgeon with increasing interest in the different visual effects of traumatic brain injury, became the founder member of Marcus Institute of Brain Health, and carried on with a lot of work and active research in improving the functioning of patients with traumatic brain segments of challenging neuro-ophthalmic situations, with prestigious positions being lining up for him in his society, 220 publications, book chapters, and more. We have with us another very dynamic and efficient neuro-ophthalmologist, Dr. Mahesh Kumar, consultant and head in Arvind Eye Hospital Neuro-Ophthalmology at Madurai, with teaching PGs for over 18 years, great admiration of his student faculty for him, and an impressive national presence. We have with us Dr. Ambika Selvakumar, head of Neuro-Ophthalmology Department of Shankar Nethralaya, with 20 years of experience, and who has authored Indian Atlas of Neuro-Ophthalmology, Atlas in Neuroimaging, and many more book chapters, invited faculty in major national and international meetings and publications, and on board of the Neuro-Ophthalmology Society of India and the international societies. We have with us our very dear Dr. Pradeep Sharma, Professor and Head of Strabismus, Pediatrics and Neuro-Ophthalmology from All India Institute, a most popular figure in Indian ophthalmology and a leader in pediatrics and neuro-ophthalmology world over, and a massive array of awards and accolades and innumerable publications in most reputed journals. The moderators are myself, Dr. Rohit Saxena, member ARC and who doesn't need any introduction, and Dr. Durga Priyadarshini. Dr. Durga is a consultant neuro-ophthalmologist from Shankar Nethralaya after a fellowship therein, and is intensely involved in the various activities and the conferences related to neuro-ophthalmology. We shall now go on to our first speaker, Dr. Jyoti. You could share your screen. Dr. Jyoti Matalia, who will be talking on problems-based learning in neuro-ophthalmology. Dr. Jyoti is the head pediatric strabismus and neuro-ophthalmology department of Narayan Nethralaya Unit 2, with a great presence in different forums and numerous publications to her credit. Dr. Jyoti?
She had joined, but apparently she's no more there at the moment. So Murli is there or no? Murli is also not there. So we're starting with
Join.
Yeah, Murli. I think Jyoti may have got disconnected. I think we should go on to Murli then. I can't see.
You want me to go first?
Rohit, will you introduce Murli?
Yeah, I'll do that. So Murli, you can start your screen share, please.
One second.
We have with us Dr. Murlidhar, who will be talking on managing paralytic strabismus. So he is presently consultant pediatric glaucoma and neuro-ophthalmology at the Eye Foundation, RS Puram, and he has done his residency and senior residency at RP Center and Murun's Eye Center, Salt Lake City. He is one of the most popular surgeons, extremely friendly, extremely nice, with huge interest in pediatric ophthalmology and neuro-ophthalmology, and has real outstanding state-of-the-art knowledge, skills, and he has conducted innumerable instructional courses, has multiple publications, and one of the finest fellows in our specialty. So, Dr. Murli, please.
Sir, thank you very much for the kind introduction, sir. And I was your student as well. So I'll be talking on management of paralytic strabismus. So we'll start with lateral rectus palsy first. So when managing lateral rectus palsy, we need to have this checklist in hand. Have neurological causes been attended? Are the systemic risk factors in check? And a complete orthoptic and motility exam. We wait for 6 to 8 months for a natural resolution if and when present. We do not operate before 6 months. And in the meantime, we can use prisms, we can use monocular occlusion, we can use botulinum toxin as well in the meantime. So this is an example. This is an adult patient around 28 years old. He presented with right sixth nerve palsy after a viral illness. The MRI brain with contrast was normal. There were no other neurological signs. The fundus examination was normal as well. And his only complaint was binocular diplopia. So he presented with history of viral illness a couple of weeks back. And now he presented with history of diplopia. So having just one minute. I'll get this video going. There is an abduction restriction. And you can see that the right abducting saccades are floating. They are floating saccades. So this is very important. The observation of saccades is very important, more so in kids, because in kids, forced adduction and forced generation test is very difficult. So we gave him a course of oral steroids and he has had complete resolution. So this is for the medical causes of sixth nerve palsy. So on cover test, you note that he's fully orthophoric. In primary position, the abduction has recovered as well. So now coming to another very important thing, that is the role of botulinum toxin. I give botulinum toxin after waiting for 3 to 4 weeks of non-resolution, especially in the atherosclerotic age group. I have used it almost exclusively for sixth nerve palsy. Only one patient with fourth nerve palsy I've used it. I give it after non-resolution for 3 to 4 weeks, and after an MRI with contrast is declared normal. So I've used it in one patient with a fourth nerve palsy as well. This is my technique. I grab the medial rectus with a rectus forceps and go a few millimeter behind with a 30 gauge needle and inject between 2.5 to 7.5 units of botulinum toxin. The amount of toxin injected depends on the primary position deviation and how much of juice is left in the lateral rectus, depending on evaluation of the saccades, depending on the motility restriction, and on the force duction and force generation testing. So now, if the lateral rectus is not working, I mean, if the recovery is not there for 6 to 9 months and Botox has not been used or has not succeeded, then we need to know in planning for surgery whether the globe is crossing the midline or not. We need to do a force duction testing and a force generation testing to see how much of juice is left in the lateral rectus. And if the medial rectus is tight or not, we need to have an evaluation of the saccade. And if yes, the lateral rectus is working, we can do a resect or a recess plicate. We can add Botox. And if the lateral rectus doesn't have any juice left in it, then we can do a transposition procedure or inject botulinum toxin. So this is an example. This patient had medulloblastoma, was suspected von Hippel-Lindau disease. These are her measurements. These are her 3x3 table cardinal gaze measurements. And this patient had non-resolution for almost 6 months. She's had neurosurgery done. The neurosurgeon said everything is fine and the fundus examination is also fine. So this lateral rectus is definitely working because you see that the globe is crossing the midline. The force generation test also showed a very good tug. So we did a recess resect procedure and we were able to align the patient in all the cardinal gazes. So sixth nerve palsy treatment is very gratifying if the lateral rectus has got adequate juice left in it. Now, if the lateral rectus is not working, there's no point in a recess resect procedure. So we have to look at some other procedure. This video is not playing. I'll try to play the video at the end if time permits. So this is how a force duction and force generation testing is done. See the abduction restriction here. So you grab the globe at the limbus, elevate the globe, not retropulse it. And a force generation testing, you try to pull the globe in the opposite direction to see if the lateral rectus is having any tug or not. So for a weak lateral rectus, we can do transposition procedure. There are innumerable procedures available, including the recently propounded Nishida's procedure. So these are various procedures. This is a Jensen's procedure. My preference is if the force duction test is negative, I would go for a Hammershim's procedure. If the force duction test is positive, I recess the medial rectus and transpose one of the vertical recti. So this is again a Hammershim's procedure. I hope the video plays. If not, I can always play it from outside at the end. So in Hammershim's procedure, we basically split the vertical recti. I'll try to play it from behind. So this is an adjustable transposition, adjustable Hammershim's. So this is not a sixth nerve palsy. This is advanced retraction syndrome in which the lateral rectus has been deactivated. So we can also do a adjustable Hammershim's procedure. So this is a left sixth nerve palsy before and after Hammershim's procedure with Botox to the left medial rectus. Please note that this deviation is huge. I'm sorry. Please note that this deviation is huge, and just a transposition procedure alone will not suffice. So we did a transposition double augmentation. That is, we did a Brooks modification of 3 mm of resection on the vertical recti, and we also used the Foster's augmentation suture. And we did not recess the medial rectus. We gave Botox to the medial rectus. So this patient has been satisfactorily aligned and is now diplopia free in right gaze and primary position. So now we go to third nerve palsy. Third nerve palsy, again the same principles apply, whether the medial rectus has got any juice left in it or not, and that we assess based on whether the globe is crossing the midline, based on the Saccards, and based on the results of FDT and FGT. Please remember to rule out ocular myasthenia gravis, because if you miss myasthenia gravis, the results would be disastrous. And in case the medial rectus has got some juice left in it, this was a patient with a clipped PCOM aneurysm. So the interventional radiologist said that the aneurysm is fully thrombosed and there's no more risk. And note that the globe is just crossing the midline, FGT, we felt a weak tug. And so we did a large recession of the lateral rectus together with MR resection, and we were able to align him in primary position without any double vision. We also did a, please note that this patient has aberrant region.
1 minute left.
Yes, so the recess resect procedure was done on the right eye, not on the left eye. So this is another patient with a complete third nerve palsy. So this is after precaruncular fixation. In case the medial rectus doesn't have any juice left in it, you have two options. One is a precaruncular fixation. I have done the LR to MR transposition also, but I mean, I will not talk about it. So my preference is for either the this thing or SR or LR deactivation. That is, you suture the LR lateral. This is the pre-op. The bottom one is the pre-op photo. This is the post-op photograph. We suture the LR to the lateral wall periosteum, and we plicate the medial rectus. We can also do a SO nasal tenotomy. So partial third nerve palsy, if in this patient, the left elevation is restricted, so we plicated the superior rectus, and this was the pre-op deviations, and you can see the alignment in the post-operative period. The elevation also has improved. This is a patient with an inferior rectus paresis. So this was after a Bulgor injury and after inferior rectus retrieval. And this is a flap tear. So we just excised. I'll just wrap up with the third nerve palsy, not to leave it in between. So this patient had a horizontal and a vertical deviation, a partial third nerve palsy. So for horizontal deviation, we operated on the other eye, and for the small vertical rectus, we did a mini plication. So we were again able to align the patient. And a predominant MR palsy where the MR didn't have any juice left in it, we transposed the superior and the inferior rectus, half tendon transfer with Foster's modification suture, and we're again able to align. So I'll wrap up with this. And
Dr. Rohit,
thank you, Murli. Wonderful presentation. I was just wondering, how do you put Botox for a superior oblique palsy? So where exactly did you put it for the inferior oblique botulinum toxin?
Yeah, sir, this was a patient with superior oblique palsy. This was a 68-year-old with superior oblique palsy, and he had a very small deviation around 12 prisms, 12 prism R by L, right superior oblique palsy. So what I did was I hooked the inferior oblique. I gave him a little bit of sedation. I hooked the inferior oblique and injected into the belly of the inferior oblique. I didn't measure the distance from the insertion, but it was roughly halfway between the LR and the IR. But that was just one case. The patient was.
So you opened and
opened
under direct visibility. Great. And a question: how long do you wait after a palsy has developed, which is possibly medical in origin, if you feel, and how long would you wait before you plan your surgical intervention?
For surgical intervention, depends on the etiology. I usually wait for 6 to 9 months of non-resolution. But if I see a patient whom I have seen at 1 month and at let's say 5 to 6 months he's had an improvement in deviation, then I would extend my waiting period by let's say another 3 to 4 months. I wait for at least 2 stable deviations separated by a couple of months and a minimum of 6 to 9 months of contact.
How often have you seen spontaneous recoveries after your paralytic strabismus caused by closed head injury?
When paralytic strabismus, I mean, a lot of studies have been there. It is roughly 50-50. The most unfortunate thing is having a third nerve traumatic palsy, because these third nerve palsies, they recover partially. Initially, the ptosis is complete and the patient doesn't report diplopia. But later on, the ptosis gets recovered, but the primary position deviation is not very great. So the patient starts reporting diplopia. So roughly, I would say in third nerve palsies, after a severe head injury, especially when the patient has undergone something like a neurosurgical evacuation of a clot, complete recovery is very, very rare in third nerve palsies. Sixth nerve palsies generally recover. I would give a conservative percentage of 50%, and the same for fourth nerve palsies as well. Complete third nerve palsies, especially those that are pupil involving and especially those associated with severe head injuries, they rarely recover completely. They usually recover partially. Sometimes they develop an aberrant regeneration, the ptosis goes away and the patient starts reporting diplopia.
So thanks a lot, Murli. That was a wonderful talk. We should now go on to our next speaker, Dr. Jyoti. Are you okay with sharing your screen now?
Yeah, just...
Yes,
I'm fine. Am I audible?
Yeah, you're audible. So Jyoti is going to be talking on problem-based learning in neuro-ophthalmology. Your introduction was over.
Okay. Yeah. Thank you. I thank AIOS and ARC for this opportunity. You can see my slides?
Yes.
Yeah, so I'm going to be talking about certain situations, how we can look at and rule out certain differentials and rightly pinpoint the right diagnosis. So I'll be describing a few cases, starting with case 1. This was a 36-year-old gentleman on tuberculosis treatment, was also on treatment for seizures, was a known hypertensive under medication, and was referred to us for blurring of vision. If you notice, the vision is fine. The color vision, the anterior segment was normal, pupils normal, and fundus was also normal, as you can see. Incidentally, I'll also be discussing 2 cases because this 2 cases about how a visual field can help reach a diagnosis. Second was a 29-year-old gentleman which had blurring of vision since 1 month. If you notice that the vision was more or less same in both eyes, color vision normal, IOP normal, and again, pupil and fundus was fine. So we have 2 situations where everything was normal in terms of our objective evaluation. So what do you do next? So one important point is do a visual field analysis. And I'm going to be discussing how this visual field analysis helped reach the diagnosis. Now, when you interpret a visual field, remember to keep your right side of the field on the right and the left on the left side as shown here. So let's see what came in case 1. As you can see, a field symmetrical in both eyes, and case 2, a similar field, but in only one eye. And let's see how this reaches the diagnosis. For that, I use the power of 6. 6 important questions that you ask when you see a visual field. First, is the field loss unilateral or bilateral? Because if it's unilateral, it's anterior to the chiasma. Unlike bilateral, it would be chiasmal or beyond it. Second, does it respect the vertical meridian? Because if it is, it will be related to lesions at chiasmal or posteriorly. What is a pattern? Which means either quadrant anopia, hemianopia, etc. Bilateral, if it is, then you have to see if the defect is homonymous. What do you mean by homonymous? It is to the one side of the lesion, whether it's in the right eye or the left eye. And these are usually a posterior chiasmal lesions. If it is bilateral and homonymous, we have to find out which side of the field it is. Like in the previous example, it will be the left side because the field defect is on the right. And then finally, if they are congruous, because the more congruous they are, we expect posterior lesion. So let's apply it in our first case. So we have a defect which is obviously bilateral and homonymous and congruous. So we'll call it as left superior congruous central quadrant anopia, which means we have to look beyond the chiasma. That means so central congruous, we looked at the occipital lobe. So let's see the representation there. This is the tip of the occipital lobe, and its representation in the visual fields is central as shown. Hence, we know that this defect will be actually caused due to a problem at the tip of the occipital lobe. And as we know, the representation is opposite. A left superior congruous central quadrant anopia will be causing by a lesion, which is a right inferior calcarine cortex. Hence, with this in mind, we did the MRI scan and it showed the presence of these cysts confirming a CNS tuberculosis. Let's look at the first case. Now we realize that the defect is only in one eye, which is the left superonasal. And as I discussed, the 6 points apply. This is anterior to the chiasma because it involves in one eye. So go back, look at your discs and retina. And if you look carefully, there's actually a nerve fiber layer defect, which is suggestive of glaucoma, probably NTG because the IOPs were normal. So this will tell you how you can go about looking at your fields and reaching a diagnosis. Let's look at case 3. This was a 45-year-old female with a known case of NIDDM, hypertension and hypercholesterolemia on treatment with sudden decrease in vision since 20 days. Vision was right eye 6/6, left eye finger counting ½ meter, left RAPD. A quick reinforcement that when you want to confirm RAPD, we're doing a swinging flashlight as shown here. And every time the light is shown on the affected eye, which is an optic neuropathy, you will see the pupils appearing to dilate because they cannot be, the pupillomotor impulse being less cannot maintain the constriction. So once you have this, you know it's an optic nerve problem. We looked at the discs, and as you can detect, there's a presence of disc edema with a macular star. So is this neuroretinitis? What is neuroretinitis? Descriptive term, an optic disc edema with macular hard exudates and plus or minus vitreous cells. And when you think of neuroretinitis, we're looking at an idiopathic or an infective etiology as mentioned here. So do you think in this times? No. What is important is go back to the history and look at it again. This patient already had ischemic risk factors as mentioned. It was a sudden painless loss of vision, indicating an ischemic onset and profound visual loss. So when you have this, again, go back and look at your discs. If you see there's sectoral pallor, there's mild attenuation of vessels. And if you do an FFA, which can be done, if the patient comes to you early, you will realize there's hypoperfusion. There was a delay in arm to retina time, confirming that this was actually a hypoperfusion at the disc. And 6 weeks later, you realize that the vision continues to remain less. And if you also notice, there is significant attenuation of the vessels, all pointing out that this is an anterior ischemic optic neuropathy and not neuroretinitis. So very important, your history and examination can reach the diagnosis. So take a good history and examine specific to the optic nerve. Now let's look at this another case, 38-year-old lady with decreased vision. Vision was less in the left eye, color vision normal, pupils normal, anterior segment and fundus normal, both eyes of visual fields, and we were thinking of sending this patient to MRI. So what important was ask the proper history. When we asked her the decreased vision, she said incidentally when she closed one eye, she was looking through something, she realized the vision is less. So before you send the patient elsewhere, do a simple test in your OPD, a 4-prism base out test or under WFDT. So if you look at this one, when you're moving the 4-prism in front of right eye, there's a movement in the right eye and left eye, if you see carefully. But when you use the same base out prism in the left eye, there is no movement in either eye. This confirms a microtropia or monofixation syndrome. And so this patient had it since the beginning. It's only that we had to detect it in time. If you do the WFDT, that is word 4-dot testing, we'll realize for distance, there is a suppression because this patient has a small scotoma. But if you do it for near, you'll see that it is normal. So this way you can diagnose and prevent unnecessary evaluation. Otherwise, she would have gone and undergone MRI, etc. Now, case number 5, this is a 15-year-old girl came with decreased vision in both eyes. If you notice that the left eye had significant less vision with an abnormal color vision, but right eye had a 6 millimeter sluggish pupil, whereas left eye had a 3 millimeter pupil with an RAPD. Now, before I move on, I want to show how you should be doing an RAPD testing in a patient who has a tonic pupil in one eye. Prior to that, we did a 0.1% pilocarpine test in this patient in the right eye, and it turned out to be positive, confirming the tonic pupil. So let's look at this. This is swinging flashlight test. Right eye is a fixed dilated pupil. We should be shining light in both eyes, but look at the left eye only because the pupil there is working. So as you move to the left eye, you will see that the pupil is dilated. But as you come to the right eye, it is constricting. So only dilates when it goes to the left eye, indicating a left eye RAPD. So if you notice that this fundus examination showed a pallid disc edema in the left eye. So we have a right eye tonic pupil, left eye anterior ischemic optic neuropathy. So when we did the visual fields, obviously significant involvement was noted. A workup for ischemic factors was needed. And this is the list of ischemic factors that you tend to do in any patient and a cardiology reference. We realized patient had hypertension. MRI brains protocol showed that there was infarcts in the MC and ACA areas, and also a block of the brachiocephalic artery, right ICA and near total ICA occlusion. So what we had in arteritic AION, because of the near total IC occlusion, a tonic pupil probably related to total IC occlusion and therefore reduced blood supply to the ciliary ganglion. So when you have this in an adult, you would always think of GCA. But in a child, you have to look at age-specific systemic vasculitis. And in this case, it was Takayasu's arteritis. And we've also published this in Canadian journals. And quickly, just 10 seconds, a 60-year-old gentleman came with a diagnosis of tobacco alcohol syndrome, 6/18 vision. But if you notice, everything was normal. But when we did see this is the normal disc, normal field. So what do? Do a simple pinhole test, which gave 20 by 20 and a PAM also 20 by 20. What was important is do a direct ophthalmoscopy, which many of us have forgotten. And that showed an oilet droplet appearance. Patient had an anterior lenticonus. And when we asked the history of hematuria, it was present. Basically, it was Alport syndrome. So I want to end by saying that you need to do a perfect visual testing with pinhole. Retinoscopy reflex is also important, refraction, and a thorough slit lamp examination. So basically, small important aspects of history, examination, if you do thoroughly, we will not miss certain things which otherwise go unnecessarily for major investigations. Thank you.
Thank you, ma'am. That was a wonderful talk. I have a question for you, ma'am. What is the protocol that you follow in evaluating NAION in the young?
NAION. So basically, it's very rare to find NAION in our children, which is usually common in adults. But then I would do, as I said, the routine systemic evaluation routine ischemic workup that I had just shown, that we would basically get a blood pressure done, get the routine diabetic workup, and show him to look out for anything which could be a thromboembolic phenomena. In children, we usually have not seen so many cases, but this was one of the cases where I got a TIACI.
And what is the incidence of fellow eye NAION in your experience, ma'am?
In my case, I've seen about 15% of cases in adults where I've got an NAION in the other eye. But anyway, as in case, if you have found out the associated risk factor and you're able to avoid it, then that could be a better treatment option. But about 15% in my practice.
Thank you so
What
much.
do you think is
Madam, I had a quick question. Chitra madam, I had a quick question to Jyoti madam. In case of these adult NAIONs, what is the preference whether to give posterior subtenon injection versus the oral steroids? If at all oral steroids to be started, in what cases? And what is your priority of the management in these cases of adult NAIONs?
So in case of adult INF, I'm not in favor of starting them on any steroids. I would like to ask Dr. Rohit for his opinion, because I usually just follow them up, find out the associated risk factor and treat that. But I have not started them on any steroids. I would leave them for arteritic, like something like GCA would be the cases where I would start them on steroid, not NAION. Dr. Rohit, do you want to add anything?
Steroids, then posterior subtenons injection would be good enough, Rohit boss?
No. Anyway, nobody's really tried the posterior subtenons, and there's very little doubt that you would really achieve much by a posterior subtenons. People have been advocating oral steroids, and of course, we'll have comments from Sachin and Prem about their experience. But as Jyoti said, there is no evidence as of now that oral steroids in any form improve the outcome, the visual outcome, although they have been shown to decrease the severity of edema. But they have not shown any significant outcomes. And unfortunately, we were all part of a very interesting trial that had attempted to see if any other alternative treatments are effective. But as of now, there is no treatment for NAION directly. And steroids definitely in those patients who are diabetic would be a major contraindication. So some people do try steroids, but like I said, it's only shown to reduce the edema early, but no significant difference in visual outcome. And a definite, increased risks in patients who are diabetic. Prem and then Sachin maybe give us an opinion of their experience, please.
Sure. So like you, Rohit, I have really stopped using corticosteroids for the treatment of patients with NAION. Absolutely for AAION arteritic disease, but not for NAION. Not intravitreally, not subtenons, not orally, definitely not IV. I think the data have just accumulated to the point where the risk of using steroids exceeds the potential benefit, which is little to none.
So then what is ophthalmology role?
Sorry, after the first paper by Dr. Here, where he said, it is useful in certain limited situations, I used it for a few years. but the risk benefit was never in favor. You had patients going into diabetic crisis, so it was not worth it. I don't ever do that now.
I think what Dr. Durga had asked is NaON in young is less than 40. I think most of the neuro-ophthalmologists would agree now is we see a lot of patients in the 40s and even 20 to 40 coming up with picture like NaON. Prem and Sachin, what is your workup plan for such patients in the absence of ischemic, risk factors? How would you proceed?
So the first thing I do now, and because I look for disc drusen, we just had a publication about the high prevalence of disc drusen in that population. So I do a enhanced depth imaging OCT to see that. And if I find significant drusen, then to me, that's often the answer. I don't do an extensive coagulopathy workup or other investigations. But if they don't have drusen, then I will look to see if they have other risk factors, if they do have some other strange coagulopathy or some other disorder that could be causing them to have the disease. The yield is low, but I think it's important to look.
Sachin?
In the age group of 40 to 50 years, we do see an occasional ischemic optic neuropathy, but less than 40, I think it's a case report. And in those cases, I pretty much do everything, starting with EDI imaging, followed by MRI orbit, and then proceeding with more invasive neurological workup after that. But less than 40, it is so unusual and rare that the patient has bought themselves a full workup at that time.
I just wanted to add that we would do the sleep apnea study. I was actually looking at, probably she was asking because I showed the Takayasu case, but in a lot of I have lately seen in last 6 months about 5 cases, and of them, we could not find any ischemic factor, but what we found was the obstructive sleep apnea studies were positive for them.
And homocysteine.
Yeah, serum homocysteine levels, right.
We shall then go on to our next speaker, Dr. Rohit Saxena. Known to all of us, very enigmatic and endearing, and is leading the Strabismus Pediatrics and Neuro-Ophthalmology Division of RP Center and holding the position of member ARC for the 2nd term without any opposition. Nobody would dare to oppose Rohit. So on to you, Dr. Rohit.
Thank you, Dr. Chitra, and I'll be talking about the current scenario of optic neuritis, which has actually undergone a major change in our understanding. So a little bit about the background. Optic neuritis is essentially inflammation of the optic nerve and could present as papillitis, where there is disc edema, a few vitreous cells, some splinter hemorrhages. The edema is moderate or mild to moderate. It's not very severe like papilledema, or it could also be not there and the nerve could get involved in the retrobulbar part, as in retrobulbar neuritis. It's usually uniocular, predominantly affecting females in the youngish age group. Acute loss of vision over hours to days. It's not immediate or sudden, which is more often or more likely to go towards an ischemic event. The vision loss may even be very subtle and may just present with a mild visual field effect to no PL. And the visual loss would tend to progress a little, would kind of plateau out by 2nd week, and then will start improving gradually with the presence of RAPD in a unilateral case. And of course, the fundus we discussed. The causes could be demyelinating, which is the most common cause with the isolated or with multiple sclerosis, and of course others like infections and inflammatory lesions. Optic neuritis with multiple sclerosis is what the ONTT had actually commented upon, and our understanding of its association is that optic neuritis presents in 50% of patients with MS during their course of the disease, and it could be the presenting feature in about 20% of patients with multiple sclerosis. And recurrent optic neuritis may be more commonly associated with multiple sclerosis. Now, these were typical features that were kind of described and summarized in the ONTT trial. And anything other than that is actually called an atypical optic neuritis, where it could be absolutely painless vision loss, older patients, bilateral involvement, very severe disc edema, hemorrhages, cottonwool spots, a lot of hemorrhages. Generally, one splinter or a bit is usually there, but a lot of hemorrhages is unlikely. Visual loss continues beyond 2 weeks. They fail to improve with treatment, or else they have multiple recurrent episodes of visual loss with significant drop in visual acuity. So essentially, when we've described typical and atypical, our understanding is that typical optic neuritis could be isolated or MS related, but is demyelinating in etiology. Although rarely other causes could present in a typical manner. atypical is most likely not due to demyelination, and you must look at all these others like particularly NMO or MOG, autoimmune, cryon, infections, particularly in our setting. So atypical, unlikely to be demyelinating, not impossible, but search for the other characters or other causes also. Essential diagnosis is clinical only because of visual loss or fundus appearance, RAPD. Absence of RAPD, unless it's bilateral, be very suspicious of an optic nerve problem. And of course, visual function deficit in the form of fields, color, contrast, visual acuity, and of course, increase in latency of the VAP. As such, for diagnosis, usually, at least in the first episode presenting with this clinical feature, you would not go in for too many investigations for diagnosis. In our setting, we do electrolytes and a chest X-ray because electrolyte imbalances have been precipitated by IV methylprednisolone, and chest X-ray because tuberculosis can flare up, and we've had a couple of cases where the tuberculosis flared up. So just as a precautionary measure. The moment it's an atypical presentation, look for all possible etiologies before you think of demyelinating and start steroids at the first go. MRI brain now, brain and orbits with contrast is almost mandatory in all patients, but because of the cost constraint in some of our patients, it becomes very important. Recurrent optic neuritis, patients keen to know about long-term prognosis with evidence of other neurological involvement, of course, atypical cases, especially if you're thinking in terms of a compressive lesion, and in children. So MRI has become the most important predictor for development of multiple sclerosis over the long term, and white matter lesions that can be seen in the brain, which are specific for multiple sclerosis or suggestive of MS, become highly suggestive that this patient in the long run is going to go on to develop multiple sclerosis. Our understanding really of the optic neuritis disease pathology came from the ONTT, which evaluated placebo versus oral steroids versus IV methylprednisolone over a follow-up of 15 years. And essentially, we learned that IV methylprednisolone provides faster recovery, although finally, long-term, finally at the end of 1 year, there was no significant difference between the three groups. However, oral had a higher recurrence rate, so therefore, oral steroids in the current standard therapy is not acceptable or should not be given. There was a 50% probability of optic neuritis developing multiple sclerosis, and MRI was the most important predictor, and those with no lesions had about 25% chance, and one or more lesions had a 3-time chance of developing multiple sclerosis in the next 15 years or so. And of course, now the recommended treatment is IV methylprednisolone, 1 gram for 3 days, followed by an 11-day oral treatment, although that may not always be essential. Also, depending upon the severity, we are also giving sometimes up to 5 days, especially if it is thought that the patient may have NMO spectrum disorder or there are clinical features suggestive. And we had evaluated dexamethasone as a comparable to methylprednisolone, especially at times when it was not easily accessible or very expensive. And essentially, the final visual acuity attained was similar in both the groups. Can we alter the disease course is something that is a very important question. Over long term, will all patients suffer disabling multiple sclerosis? So we have now disease modifying agents that can be tried and that can be treated, which can reduce the relapse rate by 30% over 2 years. So there are a lot of studies that have proven that the role of disease modifying agents in preventing multiple sclerosis developing in patients presenting with optic neuritis. So we need to discuss with our neurologist and plan the treatment in the long term. In India, we had in the initial early years, early 2000s, we used to find them to be very different, or at least moderately different from the ONTT profile. We had a high incidence of papillitis, bilateral involvement, painless visual loss, poorer visual outcomes, and we were not sure exactly what we are dealing with. And this was the scene with a lot of studies from Asian groups, Singapore, Taiwan, Japan. And over time, we have realized that probably they were the opticospinal form with an NMO positive antibody. The moment NMO antibody test came, we realized that almost 10% of these patients have NMO antibodies, showing that they are probably NMO spectrum disorder, and they were kind of misdiagnosed as multiple sclerosis. And it's very important to diagnose NMO, and of course, Rashmi will be discussing them. Their presentation is different, and their management is very different for the long term. Initial treatment with high dose methylprednisolone, but for the long term, it's important to have immunosuppressive therapy because disease-modifying drugs are contraindicated in these patients. Another test is the anti-MOG test or the MOG antibodies, and they also have their initial presentation similar to optic neuritis, but in the long term, their outcomes are different and may require long-term different treatment. So just as a brief final flow chart, an attack of optic neuritis, you do a brain MRI, you give IV methylprednisolone, associated demyelinating agents, discuss with neurologists, consider interferons and disease-modifying agents. Normal, the MRI is normal. You could follow up these patients, a repeat optic neuritis, neurological symptoms, abnormal MRI on follow-up. You again consider disease-modifying agents, no repeat episode, you could continue to follow up. So in conclusion, optic neuritis may be isolated or part of multiple sclerosis. Baseline MRI is essential, helps to predict MS, steroid speed recovery, and disease-modifying agents may reduce the pace moderately and may prevent depth transfer to multiple sclerosis. And the moment you have atypical features, investigate for different causes, consider NMO and more. Thank you for your attention.
Thank you, sir. That was a very informative talk. I have a question for you, sir.
Yeah.
When do you suspect granulomatous pathology in an optic neuritis or an optic neuropathy?
So again, the moment you have any atypical feature, so granulomatous, firstly, of course, the moment you have disc edema, you must do an indirect, because disc edemas are also associated with intermediate uveitis. And we've had patients who would obviously initially respond to steroids and would be thought as, responding as an optic neuritis, but later on come back with recurrence because of intermediate uveitis or posterior uveitis that was missed. So every patient of optic neuritis, dilate and see the fundus. Subsequently, like I said, if the presentations are atypical, you start thinking in terms of, other disorders, particularly inflammatory or one of the uveitis that may be associated in these conditions. Again, another feature which is often kind of misunderstood or misdiagnosed is a juxtapapillary uveitis or juxtapapillary choroiditis. So that also will have severe disc edema with engorged vessels. And the first thought is that it's, optic neuritis. But if you see carefully, the edema, the fluid is much more, it's deeper, the choroid gets involved in your detailed examination of the retina. But then, of course, clinical features are usually often the first signs that will tell you to start thinking of other pathologies.
Other addition I would like to make, I think Rohit has covered everything, but one addition where you would suspect that something else is going on, when you have a very fast, immediate and impressive response to steroids. If steroids is a dramatic response on first dose, you know that there's something else going on there.
Can I ask a question to Prem? Prem, do you have a condition where a patient has not responded to the treatment, first attack, MRI negative, markers negative? How do you go about?
So it's dependent on the severity of the vision loss. So I think what you're asking is, will we make a presumption that this patient could have an NMO spectrum disorder?
Exactly.
And are we going to push for a more aggressive therapy like plasmapheresis, plasma exchange? And I would say that in our experience here as a center that attracts a lot of patients who have atypical optic neuritis and in particular NMO spectrum disorder, our threshold for going to plex is low. And we tend to do it in those patients who have presented with an acuity of 660 or worse, in those patients who perhaps are atypical. They're not white. They are a little bit older. They have some other feature that makes us suspicious. And the MRI negative, that's always a little worrisome, but we have learned, I think, in our experience that we should go with the clinical scenario. And if the patient has not had response to steroid, if sometimes the labs are pending, the serology doesn't come back in time, and there is good evidence now that the faster you initiate the plex, the more likely the patient is to recover vision in the affected eye. So our threshold for doing that in the right clinical situation is low.
Would you consider an interferon, any DMD in such a situation?
I would definitely want to wait until the serology results come back and do some further investigations, lumbar puncture, looking for other mimickers, before instituting a typical disease-modifying therapy for MS because of the risk, as Rohit spoke to, of worsening an NMO spectrum disorder with a patient like that.
Prem, I think I've asked you, we've discussed this earlier, but would starting IV methylprednisolone make a difference to the serology result significantly if the testing is done at a later stage? Because sometimes patients do come to us having received IV methylprednisolone.
Yeah, that's a great question. I have the impression we don't have good data to say that IV methylprednisolone would decrease the sensitivity of the serologies for NMO or MOG, in the short term at least. Plex, absolutely, because Plex is taking the antibody out of the serum. So that will give you false negative. But with IV steroid, I'm less concerned about that. Sachin, I don't know if you have any direct experience with that or not.
No, I agree. IV steroids per se will not affect in the very short run the results of your serology tests. That being said, I will always repeat the serology twice, 6 months apart if the first one is negative, because you can have false negatives in the early stage. But with plasma exchange or even IVIG, that will affect your serology results because you're clearing the body from these antibodies.
We shall go on to our next speaker, Dr. Rohit.
Yes, and our next speaker is Dr. Rashmin. And it's an absolute pleasure to introduce Dr. Rashmin, a very good friend who will be talking on making sense of anti-MOG and anti-NMO and when we should suspect what to do. And Rashmin, after his FRCS, underwent his neuro-ophthalmology training at Wilmer Eye Institute. He's the consultant at Center for Sight and director of Foresight Worldwide, and he's taking Indian ophthalmology all over the world. And he's an outstanding person, an extremely affable and very nice person. And it's always a pleasure to listen to Rashmin. Rashmin, your floor.
Thank you so much, Rohit. Maybe I'll allow you one more minute and introduce me a little further because we have time since such a nice introduction. But thank you so much. I would like to thank Dr. Chitra, Dr. Rohit, and everybody at AIOS ARC for inviting me for this talk. A part of what I'm going to cover has already been discussed by Rohit, Ambika, Sachin, and Prem. Rohit has very nicely discussed what is typical optic neuritis, or what is a optic neuritis, typical optic neuritis as described in literature. But what do we see here, and when do we suspect the other bad forms of optic neuritis like NMOSD and MOG, and what do we do about it? That's the essence of my talk. So let's begin with this 42-year-old female with an acute loss of vision in the left eye a week ago. Her presenting visual acuity by 60 in the affected eye. She has RAPD in the left eye, while the right eye discs and fields are normal. Now, when you did the examination of and this is just a representative fundus, not of the same patient, you find that there is a florid or an impressive disc edema. So the question at this point in time is it an inflammation or ischemia? When a patient comes to you with an acute loss of vision, these are the two commonest pathologies which presents to you with optic neuropathy. So in somebody who is above 40, ischemia would always be in the mix, and sometimes it'll be as the first differential. And what will guide you would be, in our case, let's say history. Both ischemia and inflammation will present to you with acute onset, but a typical optic neuritis will have a downhill course for around 2 weeks, plateaus, and then it starts improving with or without treatment. While NAION in most cases will have loss of vision and generally will stay there, though 1/3 of the patient can have or up or down tick on the vision in the history. Now, as far as the presenting visual acuity is concerned, in a 42-year-old female who does not have risk factors of arthritic AION, we are looking at a non-arthritic AION, and a visual acuity typically in a non-arthritic AION would be around 6/60 and thereabouts. While in optic neuritis, it can be anything from 6/6 to nopia. So in our patient, the visual acuity is 1/60, which is not very common for any AION to present with. As far as the disc appearance is concerned, a non-arthritic AION typically occurs in a small disc with a small cup, what is described as disc at risk. While our patient had a florid disc edema in one eye, which is not so common in an AION, and the other eye disc, more importantly, was normal with a normal cup. So what you're looking at now is all the clinical features are probably taking you more towards an inflammation or an optic neuritis. Now, as Rohit mentioned, optic neuritis, it is not very common for optic neuritis to present with such a disc edema, or that's what we were told by ONTT. We are seeing more and more, especially in India, we are seeing more and more patients who come to you with optic neuritis and disc edema. So our first differential in this patient would be some sort of atypical optic neuritis. Now, apart from this, when do I suspect that the patient has atypical optic neuritis? ONTT, around 90% of the patient complain of retrobulbar pain or discomfort. While our study in India, the pain was not such a major factor as ONTT, but absence of pain generally tells you that maybe this is an atypical optic neuritis. Disc edema, as Rohit mentioned, always takes you towards a spectrum of atypical optic neuritis, because a typical optic neuritis does not have impressive disc edema. Bilateral simultaneous presentation does not occur, almost never occurs in a typical optic neuritis. A severe vision loss on presentation with a very little change over a period of 2 weeks or 3 weeks tells you that this is not really a typical optic neuritis. Lack of response to steroids, recurrence, and other neurological deficits is where you start thinking of atypical optic neuritis. What do we do next? As was mentioned by Prem, ONTT said that role of MRI was only for prognostication. If MRI lesions are present on presentation, then you know that this patient is going to develop multiple sclerosis. But that caveat is no longer true now, because MRI should be done in all patients, MRI brain and orbit with contrast, with fat separation. The reason being because not only that it will tell you whether patient is likely to develop multiple sclerosis, now it will also give you a clue towards what is wrong with the patient. There are typical MRI features of both NMO and MOG, which will tell you that this patient is likely to be going towards NMO and MOG and not multiple sclerosis. So again, as I said, previous belief was that MRI is only for prognostication, but now more and more we are seeing that MRI also helps you to tell the cause of optic neuritis, and that's the reason why MRI brain and orbit with contrast should be must for everybody. And why did I say that? Because if you find that a whole segment of the optic nerve is affected, or the posterior part of optic nerve, chiasm and optic nerve also is involved, hemispheric cerebral white matter, areas in the brainstem, dorsal midbrain, area postrema, which is very typically affected in NMO. So if you find lesions in all these places, you know that you are dealing with NMO spectrum disorder. Now, why this is important, why we are stressing on really finding that whether patient is falling into this group of NMO spectrum disorder is because NMO spectrum disorder is much more aggressive than typical optic neuritis associated with multiple sclerosis. The reason being, it is more likely to relapse. It is more likely to cause optic nerve damage quickly. And according to some studies, within 40% of the people within the presentation of optic neuritis is likely to develop paraplegia because of involvement of the spinal cord. And so because it is more aggressive disease, the prognosis is poor, and because they come to us first, that's the reason why these MRI features and the diagnosis or a high suspicion for NMO should always be there. These are some of the pictures showing, and this I've taken from American Journal of Neuroradiology. You find here that the optic nerve is lighting up, and also the chiasm, and the areas of the brain which are not affected in multiple sclerosis, but you will find they're getting affected in NMO are seen here, medulla, tegmentum of midbrain. These are the areas which are generally not involved in multiple sclerosis on MRI. And that's the reason repeating MRI brain in orbit with contrast becomes very, very important. The other fellow travelers, when you have suspicion of NMO spectrum disorder, is weakness or paralysis in the legs and arms, painful spasm, loss of sensation, uncontrolled vomiting and hiccups. This is typically seen when the patient has involvement of area postrema, bladder or bowel dysfunction because of spinal cord damage. What do you do next? The confirmation of the diagnosis of NMO is by ordering a blood test and see whether antibody to aquaporin 4 is present in the blood. We also
1 minute left.
NMO also can be associated with other immune-mediated disorders. So typically, we'll also ask for blood test, rule out those, and lumbar puncture will always help to find out whether there's some infection going on. And as Prem mentioned, presence or absence of oligoclonal band or presence of white blood cell, which is seen more than half of the patients with NMO. The treatment was discussed briefly. IV steroids is must. And again, this is where there is a change. ONTT said that whether you give steroids, you don't give steroids, does not matter. While for NMO and other disorders, immediate IV steroids within first 2 or 3 days would really help. Low threshold for plasma exchange and for a chronic maintenance therapy and prevent relapses as a therapy in mycophenolate for a very long time. There are some newer drugs which have been FDA approved. A word about MOG. It has a similar spectrum. It was believed that maybe it is an NMO spectrum disorder, but it is more bilateral. It is more common associated with encephalitis. The age of onset is little lesser than what you find in NMO. NMO generally seen in 40s, MOG in children than 30. Recurrence is better recovery. On MRI, you'll find perineuritis or even inflammation spilling over to the orbit and early treatment. And there is not much of a data. I'd like to hear from Sachin and Prem what's the role of PLEX, early PLEX in somebody who has a MOG antibody. So this is the last slide. We are talking about atypical optic neuritis. It can be infective or immune-mediated. Immune-mediated, you look at the blood, antibodies can be present. If antibodies is present, but there is no systemic condition, you're looking at NMO or MOG, or with systemic condition like SLE. If there are no antibodies, you're either looking at sarcoidosis or prion. Thank you so much.
Thank you very much, Dr. Rashmi. Wonderful. Some questions?
Yeah. Prem, would you like to elaborate on role of MOG? Because I'm not very sure about that. Would you also go and do early plasma exchange for somebody who has a MOG optic neuritis?
We have not really been doing PLEX for MOG-associated disease. And the reason for that is, unlike in NMO, where the aquaporin 4 antibody is clearly pathogenic, and so removing it from the body should decrease disease activity. As best as we understand MOG disease, it is a marker for the disorder, but it is not the necessarily pathogenic entity. And so the role of PLEX in treating patients with MOG, I think, is much less well proven. We have been fortunate that with MOG disease, we, like most others, have seen a very good response to corticosteroids, as you would expect. So our routine is to give them intravenous methylprednisolone and then a slow taper of oral prednisone over the course of weeks to ensure they don't have disease relapse. There's some evidence that perhaps IVIG can be useful in some MOG patients who are refractory to other steroid-sparing agents. That's work that John Chen at Mayo Clinic and others have done. I'm less convinced of the role of IVIG, and I tend to use other steroid-sparing agents instead.
Do you see this neuromyelitis optica spectrum disorders without optic nerve involvement? And sometimes the neurologists send an anti-NMO positive, and we find that there is no visual dysfunction. Is that possible, Dr. Prem?
Yes.
Sure. They could have just the transverse myelitis or some other CNS manifestation without optic neuritis. So that's definitely, if you look at the diagnostic criteria for NMO, if you have antibody positivity and core symptoms, and there are many core symptoms that are outside of the visual axis, then it is appropriate to give those patients a diagnosis of NMO. They're at high risk for developing optic neuritis without proper treatment, though.
Do you think in those subgroup of patients where there is no optic nerve involvement, but there are other features in NMO, doing OCT will reveal anything? Like in MS subclinical cases, you'll have a RNFL thinning. Do you have any experience that you'll find OCT thinning in these NMO spectrum?
Very interesting. I have not systematically looked at that population of patients. I don't know if Sachin has any experience doing that. I don't have enough data to tell you. We know that NMO's optic neuritis causes severe damage to the retinal nerve fiber layer and macular ganglion cell complex. I have some work that we've done showing early OCT angiography changes in the macula of patients with NMO spectrum disorder. And so that may actually be a better way to try to pick up subclinical damage than just structural OCT.
I have a question for Dr. Prem. What is your take on pediatric MOG optic neuritis? And what is the cutoff age for immunosuppressants in such cases?
So given the overlap between MOG positivity and ADEM in the pediatric population, I think there's a little more hesitance to put those patients on long-term immunosuppression. I think that's been the practice. I don't see as many pediatric patients maybe as some of you, so I'd be interested to know what you do. But we have been more conservative in terms of putting those patients on long-term immunosuppression. We taper them off the steroid, and then we watch them to see if there's evidence for any relapse, because it is more likely that they'll be monophasic.
And in cases of relapse in such patients?
I think, again, that has to be a co-management with the pediatrician, trying to balance those risks of immunosuppression and leading to secondary problems that we don't want. And so I think, it's a harder decision. I don't know that there is a specific cutoff that I use. There's no specific cutoff age. It's more a matter of how severe their disease manifestation is, what the risk of the further vision loss or either neurological dysfunction might be.
Because I think we have a lot of difficulty and managing these children with relapsing optic neuritis, because the neurologists are very reluctant to keep them on long-term immunosuppressions, but they do end up in our clinics with multiple episodes. The moment we come down on steroids less than 20, they start with the next episode. Because many of them have a stunted growth, chronic steroid features. You have to find a steroid-sparing drugs, and they are so reluctant to move on to the next immunosuppressant, definitely with a lot of side effects. I think we have few patients where they have put on Mycept for a longer duration, and we had a lesser recurrence. And they were those children who came with repeated relapses of neuritis, which turned out to be MOG positive disorders in our group of patients. So when you choose to do an MRI spine, when do you advise, Dr. Rashmin, in any neuritis, if they don't have any LETM or anything, or rather clinically, if they don't have myelitis symptoms, when do you decide that you need to do an MRI spine? Because we routinely ask for a brain in orbit.
Yeah, so there is a clinical suspicion that this is going towards NMOSD, but you don't get that confirmation from MRI brain in orbit, then you are looking at confirmation from spine, because as Prem said, that blood is going to take a little time for you to get the results. So that's where, and what you're looking for obviously is involvement of 3 or more vertebral segments in the upper spine. Prem?
Yeah, I think it's guided absolutely. You may get an answer more quickly with the spinal imaging than the serologies, and to support a diagnosis, particularly in those patients who, again, present with atypical features, or they are outside of the normal age for typical optic neuritis, or they have very poor vision.
Like a bilateral presentation, bilateral retrobulbar neuritis, probably you can ask for a spine to begin with. Maybe it can guide. And I think OCT, is it anything to do with the vertical segments? Has towards the polar regions, do they have an RNFL thinning much more compared to the nasal and temporal? When we do an OCT, will it give any guidelines for us?
I'm not convinced of the role in the acute phase. I'm really not a fan of trying to differentiate among different optic neuropathies in the acute phase with OCT, because I think there's just too much overlap.
As a neurologist,
I think let's move on, and we'll keep discussing subsequently, Dr. Chitra. I think.
Yeah, we would go on to Dr. Prem, who would be giving the keynote address on toxic nutritional and drug-induced optic neuropathies. On to you, Doctor.
Okay, thank you very much. It's my real pleasure to give this talk on toxic nutritional and drug-induced optic neuropathies. This is a very broad subject, and I'm going to refrain from giving you laundry lists of medications and toxins and such, because it's lovely in 2020 that we have the internet and we have these resources in which we can look up all that information. But instead, I'd like to show you several clinical scenarios in which patients with suspected conditions present, and how to approach these patients so that you make the correct diagnosis and lead down the correct path. And so I have no relevant financial disclosures with respect to this talk. I'm going to start with a case which is a little bit complex, but speaks to the challenges that we have in making a diagnosis. So this was a 27-year-old woman, and she presented to us eventually with vision loss, but her history was such that she had had other neurological symptoms, lower extremity paresthesias after a diarrheal illness. It was thought perhaps she had a Guillain-Barré type syndrome. She had had some blurred vision at that time. She had falls, problems with writing, even facial pain. And an MRI brain was performed, and this showed minimal white matter lesions in her frontal lobes. They felt that was consistent with migraine headache. And an EMG was performed, which was thought also to support this idea that she had Guillain-Barré syndrome. A lumbar puncture performed showed normal CSF, but a mildly elevated protein, and she was thought again to have an inflammatory neurological syndrome as the cause of blurred vision and systemic or other neurological signs. She was treated with prednisone. Some of her symptoms improved. She was then given, relevant to the conversations we've been having, IVIG over 4 cycles, some improvement in her facial pain, but not in her burning and weakness in her extremities. She took a number of supplements, but she stopped them because she thought they were giving her side effects. She had neuropathic pain, and so they gave her gabapentin and then pregabalin, amitriptyline. All of these discontinued because she was having side effects. And then she reported that she awoke months later with bilateral vision loss. She was 660, 2200 in both eyes, was diagnosed by an ophthalmologist who she saw with keratoconus. But he also thought that her optic discs were somewhat pale. He improved her vision to 20/80 with rigid contact lenses and referred her to the Neuro-Ophthalmology service, where we found similar visual acuities. She had no RAPD and briskly reactive pupils. She did have some temporal pallor of both optic discs, but I teach my residents that temporal pallor is one of the most difficult diagnoses to make and one of the most overcalled findings in ophthalmology. You can fool yourself by either the presence or absence of temporal pallor. So when it's very obvious, it's easy, but here I think it's a little more subtle. She had visual field testing, and you can appreciate that her foveal thresholds are reduced in both eyes. Maybe having the benefit of hindsight, you can see that she has some central scotoma, central depression, but nothing much that jumps out at you in terms of a specific pattern of visual field loss. There are high false negatives in this, and so you wonder what exactly is going on. Now, we spoke a little bit about the role of OCT in making a diagnosis in patients with optic neuropathies. And we can appreciate here that there is definite temporal thinning. This can again fool you because there is more variability in the temporal sector than there is in any other sector on the OCT analysis. But if we look at the heat map here, you can see very clearly that there is a consistent temporal thinning out of proportion to thinning elsewhere within the retinal nerve fiber layer bilaterally in this patient. So this is looking like this could be something involving the papillomacular bundle, that temporal nerve fiber layer. We look at the macular ganglion cell complex, and maybe there is preferential loss as well on the right, as well as the left eye in the ganglion cell complex that may subserve the PM bundle. But what is really going to help us to make the correct diagnosis in a patient like this is taking further history, getting more information. She reported that she had several months of excessive alcohol intake. She was drinking 10 or 12 drinks per day. And because this was providing most of her caloric needs, she had minimal food consumption. She had an unintentional weight loss of 45 kilograms. She was depressed, she lost her job because of her alcoholism, and she had stopped drinking 4 months prior to presentation. This history had not been obtained by other people who had seen her. And so she had gone through all of this extensive workup for these neurological symptoms. Her paresthesias may well have been thiamine deficiency. Her vision loss certainly fell into the category of a nutritional deficiency because she was not eating. She underwent lumbar puncture, MRI, all sorts of treatment with prednisone and IVIG because no one bothered to take a proper history and to elicit from her that she was alcoholic. I don't know how it is in India, but in North America, unless you ask very specifically, patients will not tell you about their alcohol intake. And if you do not question them very carefully and in a very open manner, you will miss this diagnosis. And the OCT doesn't always help you. These are 2 OCTs from 2 other patients I have seen over the past few years with a nutritional optic neuropathy. The so-called tobacco alcohol amblyopia is really a nutritional optic neuropathy because patients stop eating food, getting all their calories from alcohol. Here, these patients presented later with more profound vision loss, and there's just a diffuse loss of the retinal nerve fiber layer, and there is a diffuse loss of the macular ganglion cell complex in the first and now the second patient. So don't rely on OCT, don't rely on visual fields, don't rely even on your clinical exam. This is a diagnosis made by history. And to further emphasize this 44-year-old woman who had depression and anxiety was referred to me after she was seen by an outside optometrist with mildly reduced visual acuity of 6/15 in both eyes. She had no RAPD, and she had a normal ophthalmologic exam. She denied tobacco or alcohol use. She had lost about 40 pounds in the past several months and admitted to not eating well because she was depressed. And because her vision had dropped below 6/12, she was no longer able to drive and could not drive to the Walmart to do her job. She was sent to me for functional vision loss by the optometrist because she had decreased vision and normal examination. And indeed, by the time I saw her several weeks later, 6/18 vision, no RAPD, unremarkable fundus exam, but her color vision was markedly reduced in both eyes, and using a small red object, I mapped out a central scotoma in both eyes. And when we did 10-2 visual field testing, this did not really show up on 24-2 visual field testing. She had a small central scotoma in each eye that was consistent with the clinical examination, explained her decreased vision. We did serologic testing, found that she was deficient in thiamine as well as vitamin B12. We replenished her nutrients and her vision recovered to 6/7.5 in both eyes, and she returned to a productive life working in society. You can predict to some degree what nutrients might be depleted by looking at how long the patient has had vision loss. Vitamin A takes months. Vitamin B12 can take months to years, as can vitamin E and copper. But vitamin B6 in particular is depleted very quickly over the course of weeks. Folate, depending on the patient's initial status, also can be depleted more quickly. So keep this list in mind. Look for other secondary findings that can go along with nutritional optic neuropathy. But one thing I want to leave you with is that functional vision loss almost never has central scotoma. Patients will have constricted visual fields or generalized depressed visual fields, but when you see central scotoma, functional vision loss should almost fall off your differential diagnosis. And again, take that good history and look for other findings. Why do all of these problems affect the central vision and cause central scotoma? So if we look at the optic disc and macula, we look at how the retinal nerve fiber layers enter the optic disc. We know the temporal fibers and nasal fibers come in horizontally, the superior and inferior fibers come in vertically, and that PM bundle goes directly from the macula to the optic nerve, resulting in that temporal pallor as well as characteristic retinal nerve fiber layer dropout, specifically in the PM bundle that can escape you if you don't look for it early. Why is the PM bundle susceptible? It's most likely increased metabolic demand, the same reason that hereditary optic neuropathies affect the PM bundle. You have more mitochondria, more metabolic demand, and when the nutrient levels fall off, they are affected first. It may be less because of accumulation of toxin. We have some case report evidence of an actual decrease in the multifocal ERG, interestingly enough, in patients who have nutritional optic neuropathy. So that suggests that there may be photoreceptor or even RPE dysfunction in patients with PM bundle disease. And I don't think it's the first to be noticed. It is a specific effect on the axons that serve the PM bundle. A case that many of you are going to be very familiar with, seeing much more TB in India than we do in the Western world. But we are more likely to see patients who are like this, elderly, develop chronic cough, no fevers or chills. She's of Chinese origin, but has lived in the US for over 20 years. She has suspicious lesions on her chest CT, and she has an atypical mycobacterial infection, not mycobacterial TB. And here, those patients are treated with a 3-drug regimen of rifampin, clarithromycin, and ethambutol. And 5 months later, the typical time frame for the onset of a toxic optic neuropathy from drugs, she develops a decreased ability to read books. She has no pain. She's still taking the 3-drug regimen, and in fact, systemically feels well. Her cough is better. She sees a glaucoma specialist, and there's a confounding factor here, as I'll show you. She has decreased visual acuity in both eyes, no RAPD. Her fundus is unremarkable. Color vision was not tested. She sees me 3 months later. Her vision has actually improved because at this point, she has stopped her ethambutol. There is suspicion that ethambutol was responsible for her problem. She has glaucomatous cupping in both eyes, and I'll show you some visual fields in just a moment. But ethambutol optic neuropathy tends to be a dose-dependent disease. It can have an incidence as high as 6% in doses of 25 milligrams per kilogram per day. And there is accumulating evidence that there is ethnic group variability, the presence of modifier genes. I have colleagues in the Philippines in particular who have found a tremendous incidence of ethambutol-associated optic neuropathy. It's rare before 6 weeks of treatment to occur. And cessation of drug may allow visual recovery, and that's dependent upon the extent of visual field and OCT damage. So I'm not going to show you a variety of visual fields and OCTs in these patients because I think it's highly variable. The OCT may be helpful in predicting visual recovery, but this is an example, especially for some of the trainees out there, about how in a patient with glaucoma who already has a characteristic glaucomatous visual field defect, the characteristic central scotoma may be lost. And when the central scotoma develops and becomes more broad, becomes larger, these patients may have a pseudo-bitemporal defect. And in fact, when Goldman visual fields were done on this same patient at the same time that those automated fields were done, you can now see a much more characteristic classic cecocentral scotoma in the left eye and in the right eye, going along with her diagnosis of a toxic optic neuropathy secondary to ethambutol. And so the pearl I want you to take away from this, most of us don't have Goldman visual fields anymore, and we get automated perimetry on these patients. A pseudobitemporal hemianopia may be seen instead of cecocentral defects, and if you see a pseudobitemporal hemianopia with the right clinical history, be suspicious for a toxic optic neuropathy. I'll finish by talking about a confounding clinical situation that confronts us still today. When we see a patient like this with a typical NAION, he's hypertensive, diabetic, hyperlipidemia, sudden painless vision loss, disc swelling with an RAPD and a superior altitudinal defect, and a disc at risk in the other eye, we know what this is. This is NAION. But if we take a further medical history and we find out he has not only obstructive sleep apnea, for which he is using CPAP and sleeping better, but atrial fibrillation, for which he underwent a cardioversion 1 year ago. He had sotalol to try to keep him in rhythm, but it was not tolerated, so now he's been put on amiodarone. And so this patient is sitting in your office and says, "Doctor, does amiodarone cause NAION?" We know amiodarone is a drug that was developed for the treatment of angina pectoris. It was initially used in patients with serious arrhythmias like ventricular tachycardia, but is now used more routinely by cardiologists to help control AFib, especially after cardioversion. It has a very long and variable half-life in the plasma, and it is accumulated in lysosomes. The idea that amiodarone could cause NAION came from a Mayo Clinic study over 30 years ago, where they found 13 patients with optic neuropathy out of 447 patients taking amiodarone. And they felt that this was a 6-fold increased incidence of NAION compared to an age-matched cohort. So this developed the idea that amiodarone could be implicated in NAION. Since then, many case reports. In 1997, the package insert was actually modified to list optic neuropathy. But in 2007, a randomized prospective trial demonstrated no increase in optic neuropathy with amiodarone versus placebo. But there is an amiodarone optic neuropathy, and it occurs over months. So 4 examples quickly of patients with amiodarone optic neuropathy. They can have optic nerve swelling, but it's usually some pallor associated with it. There may be some disc hemorrhages. It's usually symmetric, and it is insidious in onset. So it's insidious over months, not rapid over days. It is usually bilateral. Visual acuity is in the 2020 to 2200 range, and disc swelling takes weeks to to resolve. At this point, it's been classified as a possible cause, and I think we should consider it in that way. It can cause optic neuropathy, but not NAION. So in conclusion, toxic nutritional deficiency and many drug-induced optic neuropathies affect the PM bundle. History is key to making the diagnosis. Visual fields may mislead you. Drugs damage the optic nerve through damage of the PM bundle and mitochondrial problems, but can also cause problems like demyelination and lysosomal damage. And I'll be happy to take questions from my panelists regarding these matters. Thank you very much.
Thank you very much, Dr. Prem. Questions, Dr. Rohit?
So, of course, one of the issues which we get a lot of patients of is ethambutol toxicity. And of course, the question often has been asked that how and when would you suspect that there could be INH related toxicity? So we very easily diagnose ethambutol toxicity, but any experience or idea about INH toxicity, Dr. Prem?
Sure. So again, I think many of you have more experience with this than Sachin or I do because of your population, but there are sometimes retinal dysfunction present. There is retinal dysfunction present that can be picked up by electrophysiology. So I have used that in some patients to look for concomitant INH toxicity. Again, it's not something that we tend to see commonly. And so I actually defer to you to tell me if you have particular etiologies or particular investigations that have been useful to you in differentiating ethambutol from INH toxicity.
Sure. Rashmin, any comments? Rashmin, Ambika, otherwise?
I think there are lots of, it probably would be exclusion and lots of anecdote because there are no studies or there's no data to say that, yeah, this is that. I would say, I mean, this is off the hat that ethambutol would have much more central scotoma and a temporal hemianopic-like defect, the pseudo bitemporal hemianopia. I'm not sure whether INH also produces a pseudo bitemporal hemianopia. And Dr. Bhattu, I think, wanted to say something.
Bhattu wanted to say something.
Yeah. I have seen a patient who was on treatment for tuberculosis spine. He was on INH, ethambutol, and one other drug. During treatment, he suddenly developed a rapid loss of vision. The orthopedic surgeon who was actually treating him stopped ethambutol immediately under the assumption this could be ethambutol, good thinking. But his visual loss continued to deteriorate. He was then sent over to the neurologist in Bangalore, who evaluated it, and he sent him over to me, and I found a mild disc edema, just a mild disc edema. His visual acuity recorded about 15 days prior was around 636. Now he was around 5/60. And the optic disc had started becoming pale. One thought occurred to me that this could be a rare situation of INH toxicity. And we actually stopped the INH and referred him to an infectious disease specialist for changeover of medication. He actually recovered very fast after stopping the INH. And this is all circumstantial. But we did suspect on hindsight that it was an INH toxicity to start with and not a primary and ethambutol toxicity. So this is one case report which I have not published, but one suspicion, the strong suspicion that this was an INH-induced toxicity, although it is very rare compared to ethambutol.
Although in experience, we've learned that even after stopping ethambutol, certain amount of visual loss does continue up to even a month.
Yes.
So, I mean, so for the house or for everybody who sees such a patient, please remember, let's not be aggressive in removing ethambutol, which is one of the sheet anchor treatments. So be a little careful when you recommend. Up to a month, you may have a little progression of the visual dysfunction, and which may improve after that. So, of course, this is definitely one of the ways that if you see progressive visual loss, even after stopping ethambutol, consider INH toxicity coexisting. But Any other comments?
Ambika, I think Ambika wants to make a comment.
Yeah,
Yeah.
actually, I think when we have ethambutol and INH together, as Dr. Bhattu has rightly pointed, if you see a patient with a normal appearing disc in an early stage of ethambutol toxicity, probably we can watch that patient just plugging him out of ethambutol, provided he has the classical pseudobitemporal and all those history of ethambutol dosage being higher. The moment you remove ethambutol, and he will continue to drop in vision. As Dr. Rohit has mentioned, the serum levels of ethambutol will continue to do the toxic effect on the neuropathy. And so just wait for a while. And if a patient presents with bilateral drop in vision and you're suspecting a probable toxic neuropathy, if there is a disc edema, my first choice is INH, because most of the times INH will cause a bilateral disc swelling along with it, unlike an ethambutol, because I have not seen ethambutol toxicity presenting with disc edema, but I have seen INH presenting with disc edema. And if you pull out a patient having a bilateral disc edema, if it is going to be an INH associated, they recover very fast, as Dr. Bhattu has said. So probably I would go with the appearance of the optic disc.
Dr. Pradeep Sharma wanted to have a word before we move.
From Dr. Prem about the color deficiency. Is there any particular color which is more likely to be affected? Like there are some studies indicating the blue color would be more likely to be affected in toxic optic neuropathies.
It's why I like to use the Hardy-Rand-Rittler plates rather than the Ishihara pseudoisochromatic plates, because they do have more of the blue-yellow as opposed to purely red-green. Some of it is color deficiency, some of it is contrast sensitivity loss that masquerades as color vision deficiency. So low contrast acuity may be another way to pick up on an early optic neuropathy in those patients.
I have a question to Dr. Prem. We see a lot of malignancy patients presenting to us with antimetabolites. How frequently you have come across toxic optic neuropathy with antimetabolites?
We see it infrequently, I think, but we have certainly seen it as well. So with the antimetabolites, is there any one in particular that you have found is associated with that? Because I think the ones that we have found is those that affect folate metabolism can then result in toxic optic neuropathy, and they also result in peripheral neuropathy as well. So that's been our experience, that it seems to go along that particular pathway.
Dr. Rohit, we'll move on to the next.
Yeah. So again, we'll now have an outstanding speaker again for us. The next talk will be by Dr. Satya Karna, which will be on watch out, common pitfalls in neuro-ophthalmology. And Satya Karna, again, an outstanding neuro-ophthalmologist. He practices neuro-ophthalmology at JP Hospital, Noida, with a lot of experience and a huge, very loyal patient base and a lot of wonderful cases he keeps putting on our group. So it is always a pleasure to listen to Dr. Satya. Dr. Satya, your talk, please.
Thank you, Rohit. I hope I'm audible.
Yeah, you are. Go ahead.
Okay. So let's see some pitfalls in neuro-ophthalmology. What is a pitfall? A pitfall is basically a hidden or unsuspected danger or difficulty. So when you look at this MRI, do you see, is there a lesion? Do you see any lesion? This is a plain MRI. And when you do the contrast MRI, you see how the lesion enhances. So the first pitfall is order the right investigation. You have to order an MRI with contrast. Plain MRI, according to me, is outdated. Provided, of course, the patient does not have any kidney disorder and the urea creatinine are normal. So not ordering the right test is the first pitfall. Let's see another example. A 39-year-old female who had recurrent pain in the right eye for 1 year. And she was treated elsewhere for optic neuritis with IV methylprednisolone twice with temporary relief of pain. When she came to me, she had a RAPD in the right eye of 1+. The best corrected visual acuity was 6.6N8 and the left eye had 6.6N6. The color vision in the right eye was quite poor. Ocular movements were full. And when you look at the fundus, look at the red-free picture at the bottom that shows much better. There is a disc edema in the right eye. So in essence, this patient had a persistent disc edema. It wasn't a disc edema which had resolved and recovered. So you have to think of something else. When we did the visual fields, the left eye, of course, had a few false negatives, but the right eye showed a gross constriction of the visual fields. So we go ahead and we did an OCT, which just confirmed the disc edema in the right eye, did not give us any extra information beyond that. But when we looked at the MRI, which had already been done elsewhere. If you look carefully at this MRI, you will notice that the optic nerve here on the right side has some kind of a sheathing. I mean, it is the enhancement of the optic nerve sheath rather than the optic nerve itself in the right orbit. And it is quite a long lesion. So this made me think a persistent disc edema with a patient who has an enhancing right optic nerve sheath. Look at this sagittal image here, look at this part here. And so my suspicion went towards a tumor and I asked for a CT scan. Why? Because I was looking for calcification. So now you can see a few spots here. You can see this tram track calcification. You can see another spot here, which is also seen here. So there are these few calcific spots, which confirms the diagnosis of an optic nerve sheath meningioma. And she was referred to the radiation oncologist for stereotactic radiotherapy. 80% of such cases, the vision stabilizes or improves, though the size of the lesion remains the same on long-term follow-up with stereotactic radiotherapy. So how do you avoid this pitfall? My habit is to look at the films first, assess the findings, and then see the report, and never look at the report given by the radiologist, because they are not clinicians and they will not give you all the findings that you want. Then after looking at the image, and if you feel it is inappropriate, please order the next appropriate test. Now let's change tracks here. There is a well-known entity called the great mimic. So as you can see, this patient, he has a ptosis and he has a limitation of elevation, depression, and a bit of adduction, abduction in the left eye, but it doesn't seem to be fitting into a typical third nerve palsy. So if you remember the great mimic, it is myasthenia gravis. Another case to show you an example, myasthenia gravis, which in this patient, when he looks to the right, he has a limitation of adduction in the right eye, and he has full movement in the right eye and limitation in the left eye. And when he looks to the left, he has a limitation of adduction in the right eye and full movement in the left eye. So one would be thinking of a bilateral internuclear ophthalmoplegia, but when you do the hydrophonium test, look at his eyes. They are orthophoric, and look at the eye movements. It's fantastic. So this is a very quick test, provided you have hydrophonium, of course. And this confirms that this patient had myasthenia and not bilateral INO. Another clinical sign which sometimes most general ophthalmologists miss is this. Now, when you have a patient who has persistent redness and no other history, and he's been treated for conjunctivitis and then glaucoma, and then he is just not getting better and the picture just looks the same all the time, then you have to really think. You have to look at the vessels closely. These are dilated tortuous corkscrew vessels. And see what he has on a CT scan. Even a simple CT scan with contrast can pick up there's a grossly enlarged right cavernous sinus. So this patient and this another patient, which again shows very dilated tortuous corkscrew vessels and with a dilated superior ophthalmic vein on a CT scan. And when the DSA was done, the patient was found to have a huge keratico-cavernous fistula. So this is another pitfall. Don't miss this. Dilated tortuous corkscrew vessels with proptosis is even more suggestive of keratico-cavernous fistula, and with a chemosis is 100% pathognomonic of CCF. Another case, a slowly progressive drooping of the lid following a persistent headache, and this patient had limitation of adduction, abduction was full, limitation of depression, elevation. But if you look at the pupils carefully, the right pupil is dilated. No drops have been put. So MRI brain with contrast had already been done elsewhere. Where is the lesion? What next? Should we just refer it? No, we don't give steroids. We have to do an MRA. And look at this, look at the aneurysm. Though it's so tiny, it's caused such a huge pupil involving right third nerve palsy. Another close-up view of that aneurysm. She underwent a coiling of the ICA PCOM aneurysm. And the important point here is when you have an isolated third nerve palsy, you look at the degree of completeness of the external ophthalmoplegia, that is the external dysfunction part, and you look at the presence or absence of pupillary involvement, which is the internal dysfunction part. So this is very important, and this is the pitfall you should not drop into or fall into. And so after coiling, you can see that the aneurysm has been obliterated and there is very good recovery of eye movements in the right eye. Patient was very happy. So important thing is pupils. I suggest to do pupillary
1 minute left.
In all patients in the clinic. You should teach your optometrists, your juniors, and everybody to do pupillary evaluation in all patients. This is an example of a pupil sparing third nerve palsy. Now let's come to the fourth case, which is vanishing visual field defects. A patient who had undergone LASIK but was complaining all the time. And she said, my vision is not good, my side vision is not good. And when you look at the fields, it seems as if there are constricted fields in both the eyes, but look at it carefully. It is not that. When you do and thanks to All India Institute, which has the only gold man around here, they did the visual fields and it came out fully normal. So look at this and this clover leaf pattern, never miss this pattern. You have to repeat the fields again. You have to do a gold man, but you have to get the patient out of this so that you get a fully normal field and you can prove that there is no field defect. The last case, unexplained bilateral visual loss, which is a real pitfall. A 56-year-old male businessman from Dubai who had a progressive diminution of vision in both the eyes for the last 2 years, had hypertension, was diagnosed as pituitary adenoma. The prolactin was highly elevated and the VEP showed delayed latency. So there was this field defect where you can see a temporal hemianopia in the lower one and you can see a constriction on the upper one. I'm sorry. The patient was treated as a large pituitary adenoma, which was splaying, just a few slides, splaying the chiasm upwards, as you can see in these two pictures. And the third picture. The treatment was done, but after 5 weeks of cabergoline, the prolactin had reduced, but the patient noticed a further drop in the side vision. The vision was 6/6, but when you look at the discs, there was temporal pallor and there was complete bitemporal hemianopia, which means there was a progression instead. So the patient had undergone a pituitary adenoma resection, but there was still a visual field loss. And so what did we find? We actually found a pit and the chiasm had actually dropped into the pit. Look at this carefully. You can see the chiasm, the blue arrow has gone down. This is the normal anatomy and the chiasm is way higher than the pituitary. And you can see in a normal MRI how the chiasm and the pituitary are related. But in this patient, this is another example of an empty cella where the chiasm is inked and there is an empty cella below it. And in our patient, you can see between the two MRIs, the chiasm had actually sunk into this in 2011. So the treatment for this was transsphenoidal chiasmopexy with fat graft. He retained his vision and visual fields, but then he further had bilateral loss of vision, which you see is progressive on the left eye. And then he underwent transsphenoidal chiasmopexy with silastic implant and titanium plate, and the vision was maintained. Thank you. And you're all invited to the Global Neuro Ophthalmology Case Festival on September 26th and 27th.
Thank you very much, Dr. Satyakarna. They were wonderful series of very informative examples. I'm sure the general ophthalmologist who's hearing also would have gained a lot. Dr. Rohit, questions? Dr. Durga?
Yeah, I have a question, sir. Satyakarna, sir. When do you consider neuroimaging in a pupil sparing third nerve? Or do you consider neuroimaging in pupil sparing third nerve?
Okay, so that's a very important question. Actually, even if you have a pupil sparing third nerve palsy, which is isolated and there is no other neurological sign, and the patient is significantly diabetic or has other vasculopathic factors, you consider it as vasculopathic, but you have to wait and watch and you have to review the patient within 2 weeks. If there is a pupillary involvement or if it is painful, if there is persistent pain, then the patient requires neuroimaging. Or if the palsy is incomplete and starts progressing, I think even that is an indication to get neuroimaging done.
Any role for CT angiography?
Yes. So it is, or it has been discussed on various fora earlier that even CT angiography is as good or even better than MR angiography. And therefore, I think centers which have good CT scans with angiography should go ahead and do that.
Dr. Satya, I have a question.
Yes.
So I saw a case today, patient today with pituitary macroadenoma, not quite touching the chiasm, but the imaging showed exactly the same sort of kinking like the one you showed.
Yes.
And the patient did have a early supratemporal defect in one eye. And this case did not have an empty cellar. It was an evolving pituitary adenoma. And it was exactly the same kinking effect that occurred. So I just wanted to share that information. And is it quite possible that growing pituitary adenoma can indeed kink a chiasm? It was exactly today afternoon I saw that patient. Or any other panelists, or Dr. Satya has similar experience in any other?
Yes, I believe there are reports where there is this kind of association. It is rare, but it can occur. And I think other panelists who have seen more such cases may comment on it.
I think secondary, yep, please go on. Dr.
Yeah, I was just wondering, we get some Sachin's view on.
Yes, so it depends on the morphology of the pituitary adenoma, the use of cabergoline, surgical resection. So it basically is a mechanical effect where you can either have a superior kink or an inferior kink, and you will see progressive anterior visual pathway defects. So OCT can pick it up sooner. The earliest you'll pick it up is on your visual fields. And if you pick it up before there are OCT changes, it's reversible.
We shall now go on to our next speaker, Dr. Padmavati. Could you share your screen? She's going to be talking on another interesting topic, the pupil in neuro-ophthalmology. She is the Chief of Neuro-Ophthalmology at the Aravind Eye Hospital, Tirunelveli, and we look forward to hearing your pearls, Dr. Padmavati.
A very good evening. At the outset, I would like to thank the organizing committee for giving me an opportunity to speak. I think many of my, there will be an overlap of my topic with many of the speakers. As far as pupil in neuro-ophthalmology is concerned, it is one of the diagnostic tool which helps you to diagnose many conditions, and it is also for prognosis. Suppose you see this pupil, it is in the central part of the iris, which acts through which the light rays pass through. Actually, the size of the pupil, it is controlled by two factors. One is the sympathetic system, the other is the parasympathetic system. So these are at the level of the iris. These are the factors which regulate the size of the pupil. When you see a pupil size, these are determined by the age, level of retinal illumination, emotional factors, as well as the amount of accommodation, as well as convergence. So what are the symptoms when there are pupillary abnormalities? You may have a history of photophobia or a blurred vision or a difficulty in near vision, as well as a difficulty in dark and light adaptation. So when you evaluate any pupillary abnormality, you have to ask for a history of trauma, in surgery history, occupational history, whether they have any exposure with any pesticides. The next is your drug history, past herpetic infection, or any previous history of migraine. When you examine a pupil, these are the other cofactors which you have to keep in mind. One is the lids, your extraocular movements or your ocular motility, associated vision, as well as the headache. So a brief recap of the visual pathway. This constitutes the afferent arc. When this afferent arc is affected, you have a total afferent pupillary defect or a relative afferent pupillary defect or a vernix hemianopic pupil. So when you have a lesion at the tectal area, you have an entity called a pretectal RAPD. The central path is where you have from the pretectal to the same side Edinger-Westphal nucleus, as well as the opposite side Edinger. This explains for the consensual reaction. The afferent arc goes from here to the ciliary ganglion, and to the pupillary sphincter. This is the parasympathetic efferent pathway, where if you have a damage, you have a dilated fixed pupil. So you may also have a tonic pupil or a light near dissociation. So the abnormal pupillary reactions, it could be based on the efferent or the sympathetic efferent pathway, where you have the Horner's syndrome. This is one case scenario where the diagnosis is more obvious with a history of trauma. He doesn't have the vision in the one eye, and the fundus is absolutely normal. This is an example of a case of a right traumatic optic neuropathy. When you examine the pupil, you have a grade 3 RAPD. This is a video which is taken on the slit lamp. You can compare with the normal eye, where you have a normal pupillary reflex, whereas when you swing on the other side, though RAPD is not to be, it is best elicited on a torchlight. For documentation purpose, we have taken it this way. So you have a grade 3 afferent pupillary defect in this. So what is the significance of a relative afferent pupillary defect? This indicates an optic nerve is affected or unilaterally, or you have an asymmetric involvement of the optic nerve. There is no anisocoria in RAPD. This has better correlation with visual field rather than visual acuity. It can also be seen with one functioning pupil. So when you have a dense medial opacity, you don't have an RAPD. You have only in unilateral optic nerve disease, irrespective of the cause, you can have an RAPD. So anisocoria, that is unequal pupils. So when you have an unequal pupils, you have to observe in bright and dim illumination. So suppose your light reaction is normal and good, but there is poor dilatation in dark, the abnormal pupil is small pupil. Suppose you have a light reaction which is poor in one eye and which is evident in bright light, then the abnormal pupil is a large pupil. So the abnormal large pupil has a poor constriction in bright light. The examples which are seen in a third nerve palsy, Addis pupil, traumatic mydriasis, and pharmacological dilatation. This is my young chap who met with a road traffic accident. You can see his pupil is dilated in this. This is one necessary sign which all the neuro-ophthalmologists have to be taken care, because this is associated with high morbidity. So when you see the imaging picture, he has a large hematoma which has to be drained. This is causing a shift of midline structures with an uncal herniation and compression of the third nerve. So any progressive pupillary dilatation in a comatose patients necessitate an immediate neuroimaging and a neurosurgical intervention. So this is one boy who had a pupil involving third nerve palsy, okay, and he had a ICA aneurysm. He underwent coiling and he was treated for the same. So what is the significance of pupil involving third nerve palsy? This is for detection of aneurysm, because the mortality is high with the rupture of the aneurysm. So when you see a third nerve pupil which is dilated, how do you distinguish with Addis pupil? If you put a pilocarpine drop, that too, it doesn't, it is with 1% pilocarpine, it constricts. This is my fourth case where you have a 25-year-old with blurred vision, dilated pupil. So when you shine a torch, you don't have a light reflex, but your consensual is normal. And when you see on near accommodation, you have a constriction of the pupils. This is the You have the video where you can see this is an acute Addis pupil where you can appreciate the segmental contraction of the iris. So Addis tonic pupil, here the accommodation recovers following the aberrant regeneration. Your pupillary light reflex is less and the deep tendon reflexes are hyporeflex, and the affected over time it becomes smaller. Other example of light near dissociation is your Argel-Robertson pupil, where you have a lesion in the pretectal area. This is associated with neurosyphilis and you have the accommodation reflex present. So light near dissociation of the pupil, it can occur in various conditions. One is in the dorsal midbrain lesion where you have limitation of elevation with convergence, retraction, nystagmus, and light near dissociation, and your Argel-Robertson pupil. Whereas your Addis pupil is an aberrant regeneration following damage to the ciliary ganglion.
1 minute left.
Yes, you have an Addis pupil. So abnormal small pupil is seen in where you have poor dilatation. And this is a case where this female has a small pupil on this side and she has a syringomyelia on this side. This is a case of central hornus. And this is a case of preganglionic hornus. You can watch the video. He has a ptosis and a small pupil when compared to the others, which is more evident, and there is also a dilatation lag. And he has a tumor, Pankos tumor on the lung. And this is young female who had a ptosis on this side with a ICA dissection. So when you have a lesion in this area, which is due to the stroke, that is the central, and in this region, when the cervical cord, you have a syringomyelia, and in the mediastinal mass lesion, which is a preganglionic lesion. Yes, sir, I'll finish it off. And you have a postganglionic lesion with a ICA dissection. So to conclude, if you have a normal reaction, you think the isochoria, it is normal. When you think it is anisochoria, you do a dilatation lag test. If you find it is normal dilatation, you think of physiological anisochoria. A delayed dilatation, you do the cocaine test. If it is normal, you think of anisochoria, physiological anisochoria. If it is your cocaine test confirms Horner's syndrome, but to differentiate between Horner's first central preganglionic and the postganglionic, you have to do a paradrain test. Light reaction, if it is unilateral or bilateral impact, you assess the near reaction. Light near dissociation is there. You think of this entity. If there is no light near dissociation, you have to think of third nerve palsy, acute tonic pupil, iris adhesion. To conclude, to identify the pupillary abnormality, associated cofactors, and identify the red flags. Thank you.
Thank you, Dr. Padmavati. It was an excellent presentation. The pupil was very completely covered. We've had some very interesting messages, and Dr. Sunil Morkar has actually mentioned some studies related to pupil involvement in diabetes, and he has commented that pupil can get involved in third nerve palsy, especially if the patient has a diabetic autonomic neuropathy, although that would be seen bilaterally. And therefore, that is one of the findings. So abnormal pupil probably would be present both sides. So any comments from the panelists? Dr. Bhattu, yeah.
Yeah, one comment. Dr. Padmavati, first of all, let me congratulate you on covering such an extensive topic in 8 minutes. That was fantastic. Okay. I just, one interest was in the tonic pupil, Aries tonic pupil. We normally try to use 0.1% pilocarpine to determine denervation super sensitivity. But remember, this denervation super sensitivity does not occur immediately. If you put 0.1% pilocarpine in a dilated pupil in a patient who has just had an Aries pupil, your test will be negative. Wait for 6 months, it will be positive. And I had the patient, a bilateral tonic pupil in a 12 standard girl, didn't respond to 0.1% pilocarpine. I imaged her. Imaging was absolutely normal. In fact, she had nothing else going even for me to image, but that was bothering me. Anyway, 6 months later, she came for a repeat spectacle check, and this time the 0.1% pilocarpine test was superbly beautiful. So this is one thing you should remember, that if you're confident of a Holmes AD pupil in a typical patient, you probably will have to repeat it after a couple of months.
I have a question to all Indian colleagues. Have you got access to any of this pharmacological drugs, what we do use for this pupil testing?
Looking forward to some cocaine being available now that it's in the news so much.
Honors will have any pharmacological testing available in
India
scenario. That is
because you put in your algorithm cocaine test. I was really surprised.
For completion's sake, at least you have to know what is that to diagnose between a normal physiological anisocoria as well as for a Horner's syndrome. But availability of the pharmacological agents is not available.
I have a question for the panelists. Like, how do you differentiate light near dissociation in Aries and an AR pupil?
Light and near dissociation. Can you repeat the question?
In an AD's pupil and an Agile Robertson pupil.
But in your AD's people, your light reflex is not present, whereas in your Agile Robertson people, they are reactive, they are small and reactive. That is the differentiating point.
Dr. Bhattu had some comments to make?
No, it was the same thing.
Right.
I think I couldn't cover everything in this because there are
Absolutely.
small points which you can give it. How do you differentiate between a pharmacological blockade? What is the reverse Markens done pupil? I think 8 minutes doesn't do justice for pupil.
Absolutely. Pupil is extremely extensive and extremely important and unfortunately not adequately discussed in the residency training program. There's just a question that's going around and I thought we hit it right now before we go on to another set of topics. A lot of people are asking about COVID-related neuro-ophthalmological conditions. So, Sachin, Prem, any insights into when we should start, seriously considering that a patient comes, because COVID testing is still not so easily done. So we're seeing a lot of OPD patients now, neuro-ophthalmology patient coming, anything which would suggest that we must associate it with COVID. And of course, incidentally, many may be positive with, a totally unrelated baseline disease. So any insights on COVID and neuro-ophthalmological conditions?
So I tend to differentiate between my inpatient neurology, general neurology patients and outpatient presentations. So in the hospital as a policy, we are testing everybody for COVID. I have personally seen a sudden exacerbation of multiple sclerosis. I've seen optic neuritis. I've seen a Miller-Fisher variant of GBS. I've seen various forms of confusion and encephalopathy from COVID. In the outpatient setting, I have seen only one case of optic neuritis in a patient who was in close contact with somebody who was COVID positive and turned out to be COVID positive herself.
I think the point Sachin raises is very important, which is that with other signs of COVID, then it's more reasonable to associate the neuro-ophthalmological features with that infection. In particular, that there may be some brain tropism of the virus and that it causes this confusion and other CSF findings and things to go along with the optic neuropathy. But on the outpatient basis, I think the connection between the two may be a little more tenuous.
So I think we'll move on to the next talk, and our next speaker is Dr. Murugan Subramaniam, and he's a leading radiologist specialist at Coimbatore and the medical director of a very famous Clarity Center, which is extremely famous and popular in Tamil Nadu. He will be taking on an introduction of neuroimaging in neuro-ophthalmology. So Dr. Murugan, please.
Yeah, good evening to you all, and thank you for the invitation. So, as you know, imaging plays a very crucial role in the diagnosis and management of patients with neuro-ophthalmological diseases. But unfortunately, there are so many tests, so sometimes it's very confusing as to which modality to choose for a particular clinical scenario. So the purpose of this talk is to highlight the optimal imaging combination, which will give the highest diagnostic yield, especially in an Indian scenario where we are limited with one imaging option. So as it becomes much easier for me because most of it has been touched upon earlier. In fact, this talk has been prepared keeping the residents in mind and the general ophthalmologists, so that it just gives an overview of the imaging options available and some of the queries which have been raised earlier also, I hope to address in this next 7-8 minutes. So it is MRI. MRI is the modality of choice. Of course, we have MR angiogram, MR venogram. We have CT. We will discuss where it's useful, CT angiogram, and DSA, which is a catheter-based imaging option. Now, this is some of the common indications, clinical indication: visual loss, ptosis, proptosis, diplopia, nystagmus, and your ophthalmological abnormalities. Now, this is an interesting literature. All these slides, I will say, is take-home message. In fact, this is very obvious. So this is a diagnostic and economic yield of neuroimaging, and they have clearly mentioned optic neuritis, optic neuropathy, that is slowly progressive neuropathy, and craniopalsy are the three major areas where neuroimaging plays a role. In fact, in my practice also, most of the referral from neuro-ophthalmologists is, around these cases. Now, coming to CT, now CT, the information with bony detail is very good. For example, this is just a collage of images. You can see fractures with bone fragment. You can see nice 3D pictures. You can see sinus disease with bone infiltration, calcification, as it was mentioned earlier, even meningioma calcification, CTs, sometimes MRI totally misses it out, and foreign bodies. These are some of the areas where CT is still useful. MRI, of course, it's very obvious because of the contrast resolution, the T1, the T2, and residents should always remember the sequences, the stiff sequence, which is the fat suppressed sequence, the flare sequence, fluid attenuated inversion recovery, which is for multiple sclerosis, the plaques, and of course now the DWI, that is the diffusion weighted image, which has totally taken over the infarct imaging from CT scan. So these are the three sequences you should write in the exam if a question is asked on MRI. Coming to clinical scenario, acute unilateral visual loss, non-traumatic, we start from the afferent pathways. And the clinical scenario is optic neuritis or ischemic neuropathy. As mentioned earlier, imaging plays a very limited role for ischemic neuropathy. And many times I get questions whether it can pick up the ciliary occlusion. No. At this point, the resolution of MRI is not good enough. Even MRI angiogram cannot pick up ciliary occlusion. So we are left with optic neuritis. Of course, as mentioned earlier, MRI brain with contrast is the imaging choice. And it is the stir sequence is good for picking up optic edema and flare sequence for the plaques. And as mentioned earlier, the optic neuritis treatment trial, presence of plaques means that patient is more likely to develop multiple sclerosis, more than 50% chance. So some of the images, you can see the stir sequence, even the plane itself, it's very sensitive. It picks up the edema here, the contrast shows the enhancement, and post-contrast, yes, even the optic chiasma and the flare sequence, you can see the multiple plaques. Now, comment about NMO, I think as mentioned earlier, it has got typical orientation or distribution in the midbrain. So I was listening to the talks, now I remember whenever there's a distribution away from this periventricular, we should probably extend the study to include the spine and not to miss the neuro-NMO spectrum disorder. Now, optic nerve injury, CT plays a role here because it helps to assess the fracture, whereas MRI is still useful to pick up the continuity of the nerve and edema. As illustrated here, you can see the nice bone fragment. The anatomy is so well brought out that will not be seen with MRI, whereas MRI is still useful to pick up the continuity of the nerve and also the contusion. You can see beautifully the contusion extending up to the optic chiasma. Progressive visual loss. Anything which is progressive, that means we are dealing with some compressive lesions. Unilateral, yes, MRI is the choice, and you can see a big meningioma, typically in the tuberculum cellular region, compressing on one optic nerve, giving rise to optic neuropathy. And some of the clinical cases, progressive visual loss bilateral, as it's mentioned clearly, bilateral optic atrophy, bilateral hemianopia. So we are suspecting chiasmal lesions, and MRI is the choice. You can see the central pituitary adenoma compressing, and you can even see the chiasma which is getting displaced. In an younger age group, we find craniopharyngioma more often. Again, homonymous hemianopia, we know that the lesion is more, posterior to the retrochiasmal, onset for 2 days, and MRI shows the infarct. Very typical. This diffusion imaging has really changed the way we diagnose infarct. And again, another patient with homonymous hemianopia with central sparring has got an occipital infarct here, again DW. And bilateral papillary edema is another common indications. Of course, we are looking at CVT, neoplasm or idiopathic ventricular hypertension, MRI brain with MR venogram, which is a non-contrast study. Okay, that's the investigation of choice. This is a normal MR venogram, completely normal. We can see this completely occluded. And the point we are observing now, there's a lot of CVT coming up, as was mentioned, post-COVID, they can have thrombotic complication. And I somehow feel it is added on by the fact that we are all wearing masks and we are not taking proper hydration. Maybe that is contributing to the additional incidence of CVT in this period. This is another patient with papillary edema. You can see completely normal venogram, but indirectly we find the tortuous optic nerve with distension of optic sheath, the perioptic sheath, and empty cella. When we see this, then we can mention idiopathic intracranial hypertension. Of course, this radiological finding not always correlate with the clinical observation, but it rules out tumors and other conditions. Coming to the efferent pathways, third nerve palsy is one of the common indication, as it was mentioned. Pupil involving palsy, yes, the imaging is really important, especially MR angiogram. And CT angiogram, there was a comment, and CT is definitely superior to MRI, but then the fact is, it's a contrast study, and number two, it will look at only the vessels. So If the pretest possibility is very high, then we can go for straight away CT angiogram. But then MRI will also look at the other areas. That is very important, the brainstem, other areas. So in Indian's context, I feel MRI brain and MRI angiogram should be the first choice. When we see aneurysm, probably they can go directly for DSA and coiling. Okay, so a patient with third nerve palsy with the Weber syndrome, hemiparesis, you can see the infarct nicely, the anterior midbrain. And another patient, yes, another patient, incomplete palsy, pupillary involvement, as it was requested. And yeah, there is an aneurysmal sac right here. Of course, it is better seen with CT angiogram. That gives a lot of bony detail.
1 minute left.
Section. But then MRI should be the first choice. Another patient, there was somebody was asking whether pupil sparing, whether it can be asked. Yes, but if it is associated with 6th nerve palsy, yes, this patient had 6th nerve palsy. You can see that there's a large aneurysm, a large giant aneurysm. They don't bleed. They present more with mass effect. MRI angiogram shows it very clearly. If there's a combined nerve palsy, 3rd, 4th, 6th, we know that is in the cavernous sinus. And pseudotumor cerebri is pseudotumor is one of the common presentation. You can see the contrast enhancing soft tissue in the orbital apex and cavernous sinus. Lastly, the motility disorders. In fact, internuclear ophthalmology, gaze palsy, nystagmus, where we suspect lesions in the brainstem, MRI is the modality of choice. It picks up demyelination infarct, for example. This is an infarct in the MLF region, shows beautifully that correlates with the clinical presentation. And lastly, as it was mentioned earlier, it's very important to give the clinical history to the radiologist because this patient was diagnosed, before imaging. So Dr. Muralidharan has, in fact, referred this as Brown syndrome. And lo and behold, we could see the, inflamed superior oblique tendon, which is enhancing with contrast. That makes things easier. We can even concentrate on the pathology. That is the importance of giving the clinical history beforehand so that we can target the study well. So just to conclude, MRI is the modality of choice in most of the clinical scenario. CT will be useful in trauma, in bony pathologies, when we want to rule out calcifications, or when somebody is present in an acute way, acute hemorrhage, especially subarachnoid hemorrhage. Okay, thank you so much.
Thanks a lot, Dr. Murugan. There's a lot of clarity and a very interesting talk. Any questions before we go on to our next speaker? I think we may be running late.
I have one question, sir, to Dr. Murugan. Do you follow any protocol in imaging cranial nerve palsies?
Yeah, ideally, MRI with contrast is recommended. As a radiologist, I would like to use contrast for all patients. Unfortunately, unlike in Western countries where it's all covered by insurance, here, charge is a limiting factor. So, but as a protocol, MR, thin sections, protein brain, post-contrast should be the choice. Otherwise, without contrast, we can miss some of the lesions, as it was even illustrated.
Thank you. We shall now go on to our next speaker, Dr. Sachin, who's very eminent and who will be dwelling on the approach to a patient with optic disc edema. Dr. Sachin is a professor in neurological sciences, ophthalmology, visual sciences, program director of the neurology residency program, director of neuro-ophthalmology and ocular electrophysiology from Nebraska Medical Center. He's also a chair of NANO's curriculum committee, besides all else, and has received numerous teaching awards, including the NANO's Merit Award, AO Achievement Award, AN Excellence in Teaching Certificate. His research interests include development of novel teaching methods, ophthalmic biomarkers of neurological diseases, clinical trials in neuro-ophthalmology and the impact of visual impairment on cognition, and his clinical interests involve all forms of visual disorders, including afferent, efferent, and visual perception. We are really enlightened to have you with us, Dr. Sachin, and we look forward to your talk. Dr. Murugan, could you stop sharing your screen?
Okay, sure. Thank you.
Thank you, Dr. Chitra. Can everybody hear me?
Yes, we can.
Yeah, sure.
But I think Dr. Murugan has
1 minute.
Yeah, it's okay. Okay. Dr. Sachin has shared his screen.
Yes, my screen is up, I think. It's so good to see familiar faces, colleagues and friends in neuro-ophthalmology and some of my teachers and mentors from my time at RP Center. So thank you for the invitation. So today I'll be talking about an approach to patients with optic disc edema. I have no relevant conflicts of interest for today's talk. So the optic nerve head is really unique because it is the only part of the central nervous system that we can see in the physiological state. but it is also a structure that has some anatomic challenges that make it susceptible to injury. So you can see the axons take a 90-degree curve as it enters the scleral canal. There is an abrupt transition from a non-myelinated to the myelinated state in the retrolaminar region. Also, these axons, which are initially exposed to high intraocular pressure, are now abruptly exposed to relatively lower intracranial pressure in the retrolaminar region. And this pressure differential is called the translaminar gradient. So when we do an ophthalmoscopic examination, by and large, this is what the optic nerve looks like. Either it is normal, it is swollen, it is pale, or it is cupped, most commonly in glaucoma, but also in other optic neuropathies. So why does the optic nerve have the swollen appearance? And we think it's because of axoplasmic stasis. So when the normal milieu of the optic nerve is disturbed by either mechanical forces such as raised intracranial pressure or low intraocular pressure, then there is inflammation at the anterior part of the optic nerve, or as Dr. Prema described, toxic metabolic states or ischemic states, there is axoplasmic stasis that may or may not be visible to us through ophthalmoscopic examination. So when I see a patient with disc edema, this is a very broad schema I follow. This is not meant to be exhaustive, but mostly as a guide. Step number one is to determine if the disc edema is true or not. Step number two is a vision loss or not. Step number three, is it painless or painful? And step number four, which I often use, is it unilateral or bilateral? So now I'll describe a few cases about how to approach a patient in various scenarios. The case number one is a 26-year-old obese female with blurred vision and headache, has a big BMI 55, blood pressure is normal, visual acuity is 6/9, pupils are reactive, you can see papilledema, you can see enlarged blind spots. So here you have bilateral disc edema, no vision loss, true disc edema, and we think this might be papilledema secondary to high ICP or hypertensive disc edema. So the next step in our evaluation is going to be neuroimaging. And here is a mid-sagittal MRI section, and you can see the sella turcica is enlarged. The optic nerves are also patulous. The MRV showed stenotic transverse sinus, all suggestive features of elevated intracranial pressure. More importantly, there was no tumor or space-occupying lesion. Lumbar puncture showed a significant elevation of CSF opening pressure, 50 CSF contents were normal. And so she satisfied the criteria for idiopathic intracranial hypertension, treated with acetazolamide, and she lost 10% of her body weight by about 8 to 9 months. And when I saw her roughly 9 months later, her papilledema was essentially gone. Case number two, you now have a 79-year-old female with acute and complete loss of vision in the right eye. She has headache, and she says that her temples feel sore. Her vision is bare light perception in the right eye. Left eye is 6/18, it's not normal. And her pupils are abnormal with a right RAPD. So when you palpate her temporal arteries, it is tender. So here, I don't think there's much of a differential. Clearly, this patient has arteritic ischemic optic neuropathy with a high suspicion for giant cell arteritis. Maybe you can consider inflammatory optic neuritis as probably your number 10th or 11th in your differential. So arteritic AION was suspected. She had sky-high ESR and C-reactive protein. She immediately received IV solimedrol, 500 milligrams, 3 doses, underwent a temporal artery biopsy. And as you can see from these pathologic specimens, the artery was occluded by thrombus. There was necrosis of the internal elastic lamina, mononuclear cells, and you can see the giant cells. So this confirmed a diagnosis of giant cell arteritis. She was put on long-term oral prednisone with a very slow taper, and this is before the era of tocilizumab. Luckily for her, and I've not seen this happen many times, her vision improved to 6/18 and 6/9 by about 1 year. Case number four. So this is a 45-year-old healthy female with acute painful unilateral loss of vision in the right eye for 1 week. Her acuity is 3/16 in the right eye, 6/6 in the left eye, right RAPD, full eye movements, but with pain. Neuro exam was otherwise normal. Clearly, you can see optic disc edema on the right side, normal disc on the left side. And as you move this along this pathway over here, she has vision loss, painful optic disc swelling, and you suspect an inflammatory optic neuritis. She was imaged, and here you can see contrast enhanced orbital sections showing a long segment enhancement. But more importantly, you can also see enhancement of the soft tissue within the orbit. So you're suspecting atypical optic neuritis. She received serological testing, and the pertinent positive was for MOG immunoglobulin, which is positive in a titer of 1 in 100. She was treated with IV solimedrol for 5 days, a very long, slow steroid taper. Unfortunately, she had 2 relapses and had to be put on rituximab as an immunosuppressing treatment. She remained recurrence-free at about 18 months. Last case, 68-year-old female with a 2-month history of progressive blurred vision in the right eye. Vision is reduced to 630. There's right RAPD, full eye movements and alignment, but she has a right trigeminal V1 anesthesia with loss of corneal reflex. Optic disc was swollen on the right, normal on the left. You can see that there is a large central scotoma in the right eye, but you also see a sort of a temporal defect in the left eye. So your lesion is now localizing to the junction of the optic nerve chiasm, probably the cavernous sinus because of trigeminal involvement. And as you again go along this path, there is vision loss, painless, with other neurological signs. You strongly suspect a compressive or infiltrative lesion. You are going to get imaging. And so on imaging, you can see a mass that's originating on the planum sphenoidale. You can see it surround the optic nerve. You can see it invade into the cavernous sinus, compress and elevate the optic chiasm, which is barely visible over there. So she undergoes surgical decompression. The disc edema resolves, but unfortunately, her vision does not improve. So in summary, exoplasmic stasis is probably the cause of optic disc edema from various different conditions. If you see an obvious large anterior optic nerve swelling, then that's where the lesion is. And the lesion could be ischemia, could be inflammation, or could be mechanical compression, such as from high intracranial pressure. Now, if you see bilateral optic disc edema, then it is most likely due to high intracranial pressure, high blood pressure, or other systemic metabolic conditions. For me, imaging is indicated in almost all cases of optic disc edema, especially those where you have other neurological signs and symptoms. Thank you, and I'm open for any questions.
Thank you very much, Dr. Sachin. It was a wonderful talk, as expected. Questions, Rohit?
So, Dr. Sachin, why did you start IV methylprednisolone for a patient who you suspected as arthritic ischemic optic neuropathy? I mean, would you think that it's now that we shift to IV MP the moment we suspect, or would oral still be adequate?
That's the big controversy. So I think in the US, most of us have shifted to either 1 or maybe 3 doses of IV steroids immediately after diagnosis. And the goal is to prevent the other eye or other systemic complications and then transition to a long-term oral steroid. That being said, there is no convincing data as far as I'm aware of where high-dose oral versus IV makes any significant difference. Prem, do you have any comments about that?
I would agree. I think it's the one time that hospitalizing the patient and putting them on 250 milligrams every 6 hours is actually something I like to do, because bioavailability is then more even over that 24 hours. Plus, these are elderly patients who are at high risk for steroid-induced complications. And so it's nice to have them under the care of a hospitalist who can manage those things. There are some data that suggest that if you start the patient initially on IV versus oral steroid, that their total steroid dose over time may be lower. But it's unclear if that has clinical significance or not. And now, especially since we in the US have the ability to use tocilizumab, we are transitioning patients with GCA off of their steroids more quickly in any event.
Prem and Dr. Bhattu here. Do we see a greater incidence of AION, significantly greater incidence of AION among Caucasians versus Indians? It is not very common for us to make a diagnosis of arteritic AION in India.
Arteritic AION, right.
Yeah, not very common. Whereas when I was training in Australia, we used to have a list of at least 2 or 3 temporal artery biopsies every day.
Yes, Dr. Bhattu. So we do know that it is higher incidence in the Caucasian population, especially those of Nordic descent. And this is shown through studies that was done from the Mayo Clinic.
Yeah, because my first temporal artery biopsy was done in Australia as a professor of ophthalmology being taught by a first-year resident there.
I can tell you that, I spent 3 years doing neuro-ophthalmology at RP Center, and the number of cases I saw in 3 years, I probably saw it within 1 month of my fellowship in the US.
Correct.
Absolutely, absolutely. So high index of suspicion, but I mean, the likelihood of diagnosis is relatively on the lesser side. Dr. Chitra, do we move on to the next, because we are running short of time? And so again, wonderful opportunity for me to introduce our next speaker, Dr. Himalini Samant, who will be talking on Introduction to Ocular Myasthenia Gravis. She's an assistant professor at J&J Hospital, Mumbai, and director of Eye Associates at Mumbai, with a 16-year experience and a collection of some wonderful cases and a lot of experience in treating neuro-ophthalmology. Pleasure to have Dr. Himalini here with us.
Thank you, Dr. Rohit, for the introduction. Am I audible?
Yeah, okay. You are. Yes.
Thank you, Dr. Chitra, and AIOS team, as well as the ARC team, for inviting me. Ocular myasthenia gravis is a form of myasthenia gravis, and it commonly affects the extraocular muscles, the LPS, and the orbicularis oculi. And 50% of your ocular myasthenia gravis cases progress to a generalized myasthenia gravis. So I'm going to discuss a few take-home messages, keeping this presentation exactly 8 minutes. My first pearl is that myasthenia is a great mimicker. So ocular myasthenia gravis may mimic almost anything from a third nerve palsy to a vertical gaze palsy to a superior oblique palsy. Let me show this interesting case to you, where I had a 24-year-old male. He came with complaints of sudden onset diplopia followed by ptosis, both progressively increasing. The general health was good. The ocular examination was normal, with particular attention to the pupils being normal. So this is what the patient looked like in the primary gaze. He had a ptosis with an exotropia. There was a mild adduction limitation. The upgaze seemed okay, but there was a defective, depression in abduction. And therefore, the diagnosis of an inferior division of the third nerve was made with a pupil sparing. And this patient was investigated elsewhere and then referred to me. So an MRI and an MRI angio was done, and both of which were normal. So what next? So this is the primary gaze of the patient. A simple fatigue test in the OPD demonstrated that the ptosis had increased as compared to what we saw before. And then we did a neostigmine test in the OPD, which showed that the ptosis was absolutely normal and the squint had corrected itself. That clinched the diagnosis of a myasthenia gravis. Hence, the pearl number 1 is that a myasthenia gravis can be a great mimicker. And in a patient who presents with ptosis and or squint, myasthenia should definitely form a part of your differential diagnosis. If the neuroimaging is normal, then you must do the receptor antibody test and in general, investigate the patient for a myasthenia. Now, keeping this case in the background, let me discuss another case where this was a 30-year-old lady who came with the complaints of history of trauma with a bottle on the face about a month ago. And her current complaint was that her right eye looked smaller than the left. General health was good. The vision and the rest of the ocular examination was absolutely normal, except for the right-sided painless ptosis. Patient was reassured, and I asked her to follow up with me after 15 days to a month. And promptly, so this is what the ptosis looked like. There was a mild ptosis in the right eye, and the right eye looked a little smaller. The rest, everything was normal. 15 days later, when I saw the patient again, the ptosis was just the same. The patient had developed a face turn to the left, which I observed while taking the vision. And on examination, she, along with the ptosis, had a mild adduction limitation. So my observations were that this patient had a right-sided ptosis. The ptosis seemed variable, and I kind of imagined the lid to be flickering a little bit. There was a very subtle adduction limitation, and my differentials were, could this be a myasthenia? Should we neuroimage? Or should we do any other blood workup to rule out inflammatory causes? Now, I was a little biased towards myasthenia in this case, and hence went ahead and did the receptor antibody test, which was found to be negative. So what next? Then we decided to neuroimage this patient, and to our surprise, there was a large tumor, as you see in this picture. And so what the patient had was actually an evolving third nerve palsy. So the pearl number 2 is that any ptosis which worsens over time needs to be investigated. And if the receptor antibody test is negative, the patient must be neuroimaged. MRI would be the first choice for neuroimaging. Pearl number 3, when does one suspect an ocular myasthenia gravis? So if I come across an acquired ptosis with a normal pupil, think of myasthenia. If you come across an acquired ptosis with a dilated pupil, think of the third nerve. If you come across the ptosis with a constricted pupil, think of Horner's. But if you have any acquired ptosis where the pupil is involved, where the patient complains of eye pain, where there's headache, where there's an accompanying visual loss, where there's loss of the trigeminal nerve sensation, the myasthenia gravis can be easily excluded. Well, number 4, myasthenia gravis is not a disease restricted only to adults, but in fact can present in the pediatric age group as well. So this was a 5-year-old boy who came with complaints of sudden onset ptosis, which was progressively increasing. Variability was observed during the day, and ocular examination was normal except for the right-sided ptosis. So this is how the ptosis looked. We did a simple eyes test in the OPD. This is the post-eyes test. The ptosis had improved. That clinched the diagnosis of myasthenia gravis. The eyes test has certain limitations. It cannot be used in patients with strabismus in absence of a ptosis. And if you have to, then you have to document the improvement of the squint before and after with the use of prisms. The advantage is that it's a non-invasive test and it's a good alternate to the neostigmine test and can be easily done in the OPD. This is another picture of a patient who had presented with a left-sided ptosis. We did a neostigmine test for this child. This was done several years ago. I no longer do the neostigmine test. And as you see in the picture, that the ptosis had improved. Some of the relative eye signs in ocular myasthenia gravis are the Kogan's lid twitch sign, the seesaw ptosis, and the peak sign, purely for academic reasons. And therefore, to summarize, the workup of a myasthenia gravis must include an eyes test, which can be done in the OPD. You have an option of performing the neostigmine test, which has a sensitivity of almost 80%. I always send the patients for an RNS study and the single fiber EMG studies. The receptor antibody test should be done and is positive in about 50% of the cases with OMG. I always include a CT chest in all the patients to rule out the presence of a thymoma. And in some cases, myasthenia may coexist with other autoimmune conditions. And therefore, I sometimes ask for an ANA, a rheumatoid factor, and a baseline thyroid function test where relevant. So to summarize, the management of ocular myasthenia gravis, the role of myosin, which is an anticholinesterase, you start the myosin first and then supplement it with corticosteroids. And to non-responsive cases, you can then add in the immunosuppressants, plasma therapy. Thymectomy has to be done in cases of thymoma. The role of thymectomy in patients who do not have a thymus is controversial and debatable. Thank you.
Thank you, Dr. Hemalini. That was very nice. Shall we take some questions fast before we go to our last speaker, and we could indulge with more discussion after that?
Yeah, one question, ma'am, for Dr. Hemalini. What is your take on seronegative myasthenia gravis? How do you proceed in evaluating them?
So when I find that the patient is, negative for the receptor antibody test, I do order for the anti-musk antibodies. And if those are also negative, and sometimes when there's a strong clinical suspicion of a myasthenia gravis where the patient has presented with ptosis and strabismus, which is variable, sometimes after consulting the neurologist, we do empirically start a trial of myasthine. And then if the patient does not improve, then then you start thinking of other things. You probably neuroimage the patient and refer it to the neurologist.
Because the antibodies would be present only less than half of pure ocular myasthenia patients. So you're right, Emma. You have to rely on, you have to give more credence to your clinical examination rather than the antibodies.
Are there any role of the newer antibodies, what they are claiming to, like the LRP antibodies, and there are a series of new antibodies which are coming up in the literature. Is there any role of that?
Yeah, so I haven't come across, Dr. Ambika, of any case where I've asked for this particular antibody, and I'm not sure if they are testing this in Bombay. Maybe some of the other people on the panel can throw some light on it.
Dr. Any experience, and when would you want to advise?
So the sensitivity of those newer antibodies for purely ocular myasthenia remains quite low. MuSK, LRP4, they can help to make the diagnosis with generalized myasthenia, but the data that I've seen at least would suggest that they don't have much of a marginal yield in pure ocular myasthenia.
So in these patients, I usually end up getting a single fiber EMG because I have a neuromuscular specialist who does it. And if you're doing the muscle that is actually involved in oculofacial myasthenia, the sensitivity is 98, 99%.
Single fiber EMG is fantastic if you have a good neuromuscular specialist who does them well. They're very useful.
But in children, it could be a little tricky with a single fiber EMG.
Yeah, I agree.
So, Dr. Chitra, could we go on to Dr. Bhattu and then maybe continue a few questions after that?
Yeah. Our last speaker is Dr. Ravindra Bhattu, who will be talking on defining our role in the management of IH. After stints in medical centers of repute, he started his own practice at the Bhattu Eye Center at Bangalore, and a fellow from Royal Victorian Eye and Ear Hospital at Melbourne. He continued with his interest in neuro-ophthalmology and in particular intracranial hypertension. On to you, Dr. Ravindra Bhattu. I think you should do your screen sharing. He was there all along.
Yes, it was there.
Yeah, he's just sharing.
Can you see the screen?
Yes, yes, yes.
Good evening and good morning to all of you, and thank you very much for inviting me for this talk. What is our role in the management of idiopathic intracranial hypertension? I just oft asked question here was, who should manage IIH? In the early days of raised intracranial pressure, when ICP elevation was poorly defined, it was mainly the neurologist who, working with the neurosurgeon and the radiologist, was able to diagnose something called pseudotumor cerebri and completely manage them, whereas the ophthalmologist was relegated to the backwaters, just documenting progressive visual loss in these patients without much of an input in terms of management. Evolution of knowledge into the disease, evolution of terminology. Pseudotumor cerebri gave rise to the word benign intracranial hypertension because neurologists did not believe that loss of vision was benign. And then this led to the slightly better word, idiopathic intracranial hypertension, divided into its three now accepted modalities. And then a loose word called secondary IIH, where you don't have a tumor, but you do have certain associations or certain drug toxicities which cause it. And I believe a little more accurate statement on the latter would have been intracranial hypertension due to the appropriate association or drug toxicity, to mention the exact cause in the secondary IIH patients. Advances in imaging from X-rays to contrast X-rays to CT scans and finally to the MRI and the MRV have led to increasing knowledge about the characteristics of this disorder. Non-interventional radiology has given place to interventional radiology, allowing us to not only monitor the intracranial pressure, but also to intervene in certain cases of IIH. Drug therapy has evolved, starting from the most commonly prescribed and even today my favorite drug, Diamox, to other diuretics. And finally, we are looking at other investigational drugs that are being tried in limited cases, which show promise of exciting results. Some of the greatest fields, changes that has happened is in the field of ophthalmology, where we have better methods of contrast vision acuity checking, ultrasound evaluations of the optic nerve and the retrobulbar optic nerve imaging and measurements, ocular imaging, dish photography, infrared photography, ocular coherence tomography, which is playing an increasingly important role in the management of several disorders, one of them being papilledema and IIH, and the switchover from the old-fashioned kinetic perimetry to static perimetry, reproducible, and probably the single most important change that has happened in ophthalmology so far. So, what is the change? The change is this. We are now taking a center stage in the management of IIH, helped along by the neurologist, the neurosurgeon, the interventional neuroradiologist, basic scientist, researcher, endocrinologist, nutritionist, bariatric surgeon, and maybe the geneticist. Looking at the terminology, I'm going to be specifically restricting myself to IIH, idiopathic intracranial hypertension, which follows a very typical phenotype. And you're seeing that most of our patients here are obese women in their reproductive years. Reproductive years. And they follow a typical pattern of visual loss and lifestyle. One of the problems that neurologists do have when they try to evaluate IIH, when they're acting alone without the help of an ophthalmologist, is a presentation. Relief of any of these symptoms does not normally necessarily imply that CSF pressure has been normalized, because every patient may develop any of these symptoms at any level of intracranial pressure. This is where a neurologist is usually handicapped. So IIH diagnosis is usually made on the basis of seeing a typical patient, an obese woman in her reproductive years with a recent history of weight gain and probably has PCOD. She has the symptoms attributable to raised ICP. Neuroimaging will reveal a flattened cella, a vertically tortuous optic nerve with increased subarachnoid fluid, probably an empty cella of varying degrees, and follow-up MRV may or may not reveal varying degrees and focalities of transverse sinus, the venous sinus stenosis. An ophthalmic examination done in these people will show papilledema of various grades, or even up to a pallor, a frank or subtle sixth nerve weakness. The disc, in some cases, may be actually be flat. There are patients with IIH without papilledema, and it's very, very important to look for venous pulsations, either spontaneous or inducible on these discs, to suggest a raised pressure lurking behind in a symptomatic patient. Look for ocular causes of disc swelling. Patients have been treated for bilateral optic neuritis and turned out to be bilateral VKH. Last but not the least, please check the blood pressure, because patients referred to me for IIH have sent to the ICU with blood pressures of 260 by 170 after just having a quick look at the nature of the swelling. Ophthalmic beads and ultrasonography is one of the simplest things to do. I use a lot of it in my practice. It has not been described much in the literature, except recently to try and look at the optic nerve head size in an axial section. But what I do is a modification of what is described in the textbook by Sandra Byrne and Ronald Green. And I do a B scan of the transnasal section, and you can see a crescent of clear fluid CSF around the optic nerve head, done easily in 3 minutes. Done easily in 3 minutes flat, and you can see the crescent beautifully. This is a qualitative test. It shows you that the CSF is contributing to some or all of the patient's edema or symptoms. Disc photography, is serial disc photography mandatory? Yes. Is stereoscopic disc photography mandatory? Probably not. Preferably the same machine with the same magnification. Will printouts do? Definitely not. One has to see the digital pictures. This will tell us, this will tell us whether our current intervention is effective and at what rate it is effective. Follow-up serial photography will show a disc which is characteristically now the floods are receding and you can see the disc becoming dry. This is the right eye of the same patient who was treated with high doses of Diamox and who referred to me for an optic nerve sheath fenestration. He is now completely cured, about 8 months on. OCT in papilledema has now come of age. More and more abnormalities are being detected in the papillodematous phase and in the post-papillodematous phase, and its potential for research in this field is enormous. There are some of the important things I had to pick up because I personally do not have an OCT, nor do I use OCT routinely in my practice, which I probably should be doing. And this is going to be a major investigational tools in the year to come. Perimetry, probably the single most important criteria to determine the starting dose and subsequently the taper and then the maintenance dose of Diamox. Which machine? Doesn't matter. I prefer a 32 dash program, although most of the trials use 24-2. The key statistical parameter is the deviation of the mean. The MD will tell you whether you're on the right track in managing the patient. This is a patient whose disc you have seen earlier showing a gradual improvement of the mean deviation. Right eye, left eye, and then right eye. So what determines the initial dose? Is it the photographic severity of the papilledema? Is it the height of the CS on manometry? Or is it the severity of visual loss? Is it necessary that all these three correlate? Not necessarily. My personal decision to base the initial starting dose is entirely based on the amount of visual loss on perimetry. I'll just skip this. A beautiful article was shown how an optic nerve, the amount of disc edema does not necessarily correlate with the CSF pressure. This was a study done showing the histopathology of the optic nerve sheath. Follow-up duration of these patients is going to be weeks or months. The follow-up duration is going to be for many, many years because this is not a disease like diabetes or hypertension which lasts permanently. It is a self-limiting disease which has remissions and exacerbations. And for this reason, these patients should be followed up very, very carefully for years. The nature of the follow-up, how soon you need to follow up, depends upon what stage of the disease this patient has. And these are some of the, I will skip this, which is weight reduction is a very, very important method of decreasing the necessity for Diamox or necessity for other interventional programs. When do I surgically intervene? Surgical intervention is indicated in the event of progressive visual field loss and uncontrolled pressures despite maximally tolerated medical therapy, a principle I follow resembling a glaucoma paradigm. These are some of the surgical options. My current options are: 1, conservative; 2, I prefer a TP shunt to an optic nerve fenestration, or a TP shunt with an optic nerve fenestration. Follow-up is lifelong, but the rate of follow-up depends upon what stage, what is the degree of papilledema, and what stage is the visual field loss. Thank you very much.
Thank you very much, Dr. Bhattu. Dr. Rohit, do you have any questions to ask?
So, Dr. Bhattu is, of course, now he says that he doesn't do that much surgery, but he's one of those who pioneered optic nerve sheath fenestration in India, actually. And I personally looked at his videos, initial videos, and now, I mean, like, of course, we do it very frequently, but that's it. So, Dr. Bhattu, when would be your indication to plan an ONSF?
See, if I have a patient who has got fulminant IIH, rapid loss of vision, and the vision loss is to an extent where the cannot be easily recorded on a Snellen chart, massive papilledema, and the patient is at risk of and other significant neurological symptoms, then I would like to go in with the neurosurgeon. While he does a TP shunt or a VP shunt, I will do an optic nerve fenestration.
Oh.
Right? 2, a patient who comes to me at end stage disease, where he's got vision of finger counting close to face, and who has previously already had a TP shunt done. And if I detect fluid on the optic nerve on an ultrasound, that is enough excuse for me to realize that there could be some function, there could still be significantly raised pressure. Do I do a repeat LP? I would prefer to refer this to a neurologist. I'm not primarily a neuro-ophthalmologist. I will refer the patient to a good neurologist and ask him his opinion. And if he wants to do an LP and record high pressure, then I will go ahead and do a optic nerve fenestration on this patient. The indications for my doing fenestration have in the recent years become largely more emergency and semi-emergency rather than as a primary resort. I have a paper on early intervention in early damage due to papilledema, and I believe that years have taught me that I was wrong.
Good to hear that. Although people, I'm sure Jyoti here also, a lot of us have become a little more, I would say, aggressive while doing optic. In fact, our neurologists are probably more aggressive than us. They keep referring patients for ONSF even when we feel that they have not given adequate or complete medical therapy. They somehow believe more in homeopathic doses of acetazolamide, but that's it. Any comments, Sachin and Dr. Prem? Anything, all the topics we've discovered.
If I get 50 references for ONSD, I actually decompress one. Sure. I manage the other 49 with just medical therapy, weight programs, and good counseling.
One of our studies here from our center has shown a significant impact of weight reduction. Dr. Swati had led a thesis which had shown a significant reduction of weight does help in the long-term control and early reduction of acetazolamide. So
2.5 has shown to be very effective.
Yes. Very difficult to do, probably as difficult as the optic nerve sheath fenestration, but
but that's true. Actually, people don't advocate it. What? Sorry, Dr. Sharma. Sure. I said a lot of times we have to re-emphasize that weight reduction is mandatory, and that is overlooked. A lot of people don't realize, and sometimes it's only the last, like in lockdown, couple of people would have pulled up weight only in that time. So many times that is missed. So it may not be that the patient is overweight, but they have picked up a lot of weight in that last couple of months, which is also good enough to reduce.
In fact, when the study, the question which was raised by the other people was that, do you envisage that the weight loss would be achieved in 2 months' time that you are planning to do a study? And it didn't work. So
Dr. Sharma, it's practically impossible.
Say about was the SDOCT following up with Cooper Smith's work. And that's again a very good investigative tool in papilledema cases. Following the RP Brooks membrane angle with the sclera. And we have found that just not differentiating the cases of papillitis and early papilledema, it also helps in prognosticating the cases of papilledema. We see over a period of time this change in the positive angle of RP Brooks membrane with the sclera. So this is something which is non-invasive, which can be done. And we have found it useful.
Dr. Prem, Dr. Sachin, any comments on anything we've been discussing thus far?
Dr. Ambika has a question to Dr. Bhattu.
Yes.
Dr. Bhattu, have you ever advised any of your patients a venous sinus stenting?
I have had 2 patients who have undergone a venous sinus stenting, but that was purely a decision made by the neurosurgeon and the neurologist and the aggressive neuroradiologist over there. But she's doing very well. She was a lawyer who was on 8 tablets of Diamox for 8 months. And I think the Diamox was getting to her because she was about to dissolve her marriage. So I said, it's time to intervene.
One question I have for Dr. Sachin. So what is your take on IIH in a patient with normal BMI?
It happens. Let's start with that, but it is extremely uncommon and rare. It's what we call as atypical cases. And I think a few years ago, my colleagues and I wrote this paper from Emory, where if you see such cases, then you have to investigate them to the hilt for a secondary cause. So always look for mimickers like CNS inflammation, venous sinus thrombosis, maybe even a spinal block. So anything else before you blame it on IIH. So of the 5-6 patients that I've seen in my practice, I can tell you that almost all of them had something else. So one of them had a low flow dural AV fistula as a cause of papilledema. And as soon as that fistula was blocked, the papilledema went away. Another patient had a spinal block at, I think, mid-thoracic level. And once that was fixed, the papilledema went away. So always exercise caution in those patients.
I completely agree, because most of my atypical patients have been either on excessive doses of retinoic acid creams for acne, or mothers have been feeding them a lot of vitamin A gummies, or they've had severe bleeding because of menorrhagia. And once the hysterectomy was done, their IIH, the so-called IIH, disappeared overnight. Women who are given progesterone estrogen combination pills for regularized menstrual irregularities, they come with papilledema. I have had quite a few antipsychotic medication related IIHs, but it is all presumptuous rather than a definitive thing, based on a couple of case reports reported in the literature, but these patients had them. And I agree with you. You do not have the typical phenotype. You need to investigate. You need to take a detailed history. You need to, the particular disc edema which I showed you was a young, thin MD psychiatry student from Nimans. He was sent to me so that I could convince him to undergo a TP shunt by the director of Nimans. So when he came to me and showed me his papilledema like that, I said, why don't we manage you conservatively? And I did. It took about 4 months for him to settle. And then we found out why he was having it. See, he comes from North India, the plains of Uttar Pradesh. He's come to Bangalore at 3,000 feet above sea level, and he had developed a secondary polycythemia to an extent where he had to be bled. He's gone back to Delhi. He's gone back to Rohtak actually, with absolutely no Diamox required anymore. So that gave us breathing time.
So one thing to remember is the disc edema is because of axoplasmic stasis. So it's intraneuronal edema rather than extraneuronal. And you can think of any number of causes for optic disc swelling, with mechanical being just one of them. So if you follow that kind of an approach, you will immediately see you have to exclude other causes before you blame it on just IIH. So blood pressure being one of them, that's basically vasomotor instability. You can have toxic metabolic causes. Sometimes they present acutely, but that kind of florid disc edema is rare. You see mostly a mild kind of an edema in toxic metabolic.
Dr. Sachin, how frequently you have made a diagnosis of unilateral IIH with papilledema?
I would say I can count it on my fingertips. And those are unusual cases. Again, you may have significant discrepancy in disc sizes on the two sides. You might have atrophy on one side, a burnt out edema on one side, and edema, the so-called pseudo-Foster-Kennedy syndrome. But again, it is uncommon, and almost always I attribute it to some difference between the right and the left eye. I had a patient with unilateral fenestration who developed edema in the other eye. So I can probably explain why they had unilateral, but it does occur.
We're done with the questions.
I have a last question to Dr. Bhattu. How do you manage IH patients with in pregnancy? A pregnant patient comes and the bilateral disc edema, and it's a real challenge.
Well, if I see it all depends. Many times you see a patient before they get married or before they get pregnant, even though they're married. So I tell them, don't get pregnant for some time, right? If you really plan to have a baby, you need to stop Diamox at least 2 to 3 weeks before you think of conceiving. Forget about, missing your first period. Okay. And that's very, very important because it's very teratogenic, because particularly so if they're on steroid. Now, during the pregnancy, I strongly recommend that they watch out for symptoms of all the important symptoms of headache. Try to keep a weight gain chart. Try not to put on too much weight. But of course, sometimes it's not possible. And ask them to come for regular checkups for me to, monitor their papilledema. Now, believe it or not, there are 2 patients of mine who decided to have babies, got pregnant, the papilledema disappeared until after they weaned the baby. And the papilledema came back after they weaned the baby. And that's very interesting. That's very interesting. But I always warn them that you may need a draining LP 2 or 3 times during your pregnancy if there is a threat to your vision, but this advice has to be given.
So you mean to say that you stop Diamox if they get pregnant?
See, there are controversial points. In the first trimester, it's a strict no-no. Some people believe that after the first half of pregnancy, it may be safe to give Diamox, but why do you want to take a chance? I don't like to give Diamox in pregnancy.
Maybe the other panelists could comment, Dr. Prem, Dr. Sachin.
I do use Diamox when necessary in pregnancy. I think your options are sometimes limited. Years ago, I did some work with Kathleen Degree and her husband, who is a perinatologist and at high-risk obese. And his take on it was, you do what's necessary to protect the mother's vision. So he was actually in favor of using Diamox in appropriate situations. He felt that the risk of it was lower than the risk of vision loss in patients with significant papilledema, and he was actually an advocate for it.
Yeah, so I think Nanos, if I remember correctly, has a position statement saying Diamox is actually safe with no reported cases of teratogenicity. How I approach patients in pregnancy is it all depends on their baseline vision. If their baseline vision is not good, then I will start them or keep them on Diamox, and it depends on visual fields and OCT assessments. If they are already on Diamox, if they are back to normal, I will take them off of it. But if it's a vision threatening, then I treat them as I would treat a non-pregnant patient. Now, you would avoid unnecessary imaging studies, especially CT scans. But again, you can always do an MRI, and you would do it without contrast to rule out, space-occupying lesions or venous sinus thrombosis. But I still use Diamox when needed.
I think one thing which is a big no is topiramate, I suppose. If they become pregnant, stop topiramate. But still there are groups which believe that you can continue Diamox in a pregnant patient, provided keep a follow-up with the OBG and your ophthalmologist.
You see, the problem here is
ophthalmologist in the US probably continues Diamox during pregnancy, especially after Nanos put out a statement. I'm not aware of anybody who would stop it, but topiramate we know has a problem with Epstein anomaly, and so we don't. Even in epilepsy patient, we choose not to keep them on it unless they have intractable epilepsy.
Chitra, you're muted.
Yeah, done with the questions. So thank you one and all of you for a very wonderful webinar, which was packed with pearls of wisdom. Our special thanks to our esteemed expert panel for an immense contribution and the knowledge transfer, a very eminent team and very respected speakers, my most energetic moderators, and each of you in this audience. Our special thanks to the AIR's admin under Mr. Kripal and Mr. Sunil for their technicalities. Our thanks to Sai and Manjula for their constant support and guidance. And thanks to my very dear ARC team for their support and presence. Our special thanks to Entoad for sponsoring every ARC program and allowing so much scope of education information transfer. Thank you one and all of you. Till we meet again.
Thank you so much.
Thank you, everybody.
Thank you, everybody.
Thank you very much.
Thank you. Thank you.
Thank you.
Okay.
Bye.
Bye.
Bye. Thank you so much.